Dr. Fearon is online.
No, I'm in contact with him.
So we need to wait for him, or because he's the first speaker. He will be the first speaker.
Yeah, maybe.
Do you think he get the information about changing the link address?
He didn't respond to the email last night, so I will email him again.
If that's the case, we can order of presentation so that maybe Dr. Fearon can join the meeting later, so that we can switch.
Yes.
Order.
Okay.
Yes, I agree with you. So start, please. Okay. Dear distinguished panelists, so I'm going to start now. Okay. I'm Wang Jian from Second Affiliated Hospital. Now I'm going to start the delivery remarks. Dear distinguished panelists, audiences, and organizers, good morning and good evening to you from different parts of the world. Please allow me to welcome all of you to join JACC Asia webinar series, Coronary Physiology Update. I feel so honored we have an international and respectable panel today. They are Dr. William Fearon from Stanford, USA, Dr. B.K. Koo from Seoul National University, Korea, Dr. Jian'an Wang from Essen Medical Center, Korea, Dr. C.W. Nam from Keimyung University, Dongsan Medical Center, Korea, Dr. Tan from Singapore, so Dr. Pu Jun from Shanghai Lijun Hospital, China, Dr. Guo Lijun from the Third Hospital, Beijing University of China, Dr. Chen Lianglong from Fujian Xiehe Hospital, China, Dr. Zhang Junjie from Nanjing First Hospital, China, Dr. Xinyang and Dr. Jiang, both from Second Affiliated Hospital, Zhejiang University, China. So also I would like to thank all of you for your great contribution to JACC Asia, including submitting your excellent manuscript, reading thoughtful comments, and reviewing papers. So thank you so much for joining the webinar. Now I'm going to share several slides with you about introduction to JACC Asia. JACC Asia 没看就，那你要考一下，你刚才JACC Asia 的介绍没看一下？不是这张，那这次，我回来考一下。Sorry, I need to quick copy. JACC Asia 不是这个，不是这个，不是这个。刚才我考过你们，不是这个啊，这个 OK。放一把。你有没有 share? So can you see my screen, the PPT?
Not yet.
你要分享，你要分享。 这个是分享，分享下面有个分享啊，再点开了这个，哎，对，那就这样。Can you see?
Yeah.
Yes.
Okay, good. The title of my presentation to introduce you the JACC Asia is Shape the Future of Asian Cardiovascular Community. JACC Asia is a new journal of JACC family. Until now, JACC family has let me count 1, 2, 3, 4, 5, 6, 7, 8, 9. Actually, until now, JACC family has 9 members, but they are going to have a new member very soon as a JACC Advance. So here I listed the starting time of different members of JACC family, also impact factor. So JACC, the impact factor of JACC already rise to 24, and the whole JACC family looks like having very good impact factor. So JACC Asia is the first regional specific journal of JACC family. It is an online and only open access journal. The first issue has been published on June 15, 2021. So what are mission of JACC Asia? JACC Asia is going to publish original research on Asian population-focused cardiovascular diseases. It will highlight cross-disciplinary studies and the comparative studies between Asian and the rest of the world. JACC Asia will nurture and encourage Asian-based investigators to conduct high-quality cardiovascular research based on Asian data. Prevention is also JACC Asia's responsibility. So we inspire submission of prevention of cardiovascular disease and improve the prognosis of this type of articles. Here's the model of JACC Asia. So each letter has different meanings. So JACC Asia is always on the way. So it's a journey. Accessibility means the journal is an open access journal. So cultivation means the JACC Asia has a responsibility to do the education, to cultivate the young talents in Asian cardiovascular community. So JACC Asia will have a widely collaboration with experts, international experts, with famous institutions, with other journals, not just the JACC family, but also the other journals outside the family. The JACC Asia is actually it has its own advantages. It will provide a high quality service. So innovation is novelty is so important for publication in JACC Asia. So JACC Asia is always expect the staff and investigators to work together to have a better future. I'm so honored I have the opportunity to work with a wonderful and engaging editorial board. So besides me, we have 3 deputy editors. Dr. D.W. Park, he's a very good international cardiologist. Dr. Xinyang Hu, she's a very famous EP expert. Dr. Zhao Dong, he's quite good at epidemiology. Actually, she submitted a wonderful review in the first issue of journal. Professor Chen Dai is also a very good international cardiologist. Work as a AE. Professor Jiang from Taiwan is working as an AE. Dr. Fu is also work as an AE. Dr. Kubo and Dr. Lam both work as an AE. So there are many article types you can check on the author instructions. So there are two types are quite unique in the JACC issue. One is the cutting edge technology. The other one is Zoom-in. So cutting edge is we inspire to submit some new technology just emerge in the, maybe you have just finished the big animal study or just start the first in man or some of the feasibility studies. So the Zoom-in is focused on the education, focus on one area to do the education. Until now, we have a total submission from February 9, we already have total submission more than 140. So most of the original papers every year growing very quick. So here I listed the contributions from different countries and different areas. So until now, the acceptance rate is 13%. So rejection rate is 37, but the others still pending, are waiting for the revision. With your great support and so many experts from the world, the support. So the first issue has been released. There are two wonderful reviews and 6 original articles, plus 6 editorials, and 1 research letter and 2 landscapes were published on the first issue. So what is a JACC issue looking for? We are looking for original research, cutting edge technology, and clinical recommendations. Especially we need we have not published clinical recommendation on the JACC issue on the first issue, so we are welcome clinical recommendations. So including consensus and guidelines from different countries or areas. So we are looking for cross-disciplinary studies where Asian researchers hold a competitive edge and comparative studies between Asia and the rest of the world. So we are looking for the high novelty, high quality, and ethics manuscript. Thank you for your attention. That's all for my introduction. Thank you so much. Now we move to the session 1. Dr. Koo, Dr. Nam, and Dr. Chen, and Dr. Hu, please welcome you to moderate the session 1.
Okay, so hi everyone, I'm Dr. Bu from Seoul National University Hospital, and it's my great honor and pleasure to co-moderate this session with Dr. Nam and Dr. Chen and Dr. Hu. So there will be several presentations related to the physiology, mainly physiology and different subsets, so that as far as I know, so Dr. Fearon has some problem in connecting to this meeting. So
no, he already online.
Oh, okay, that's great. So that it's my great honor and pleasure to present the first speaker, Dr. Fearon, so who is very well-known physiology specialist, and he's going to present about the coronary physiology in the cath lab. Bill, please.
Thank you, Dr. Koo, and thanks for the invitation to be part of this symposium. I'll share my screen. Okay, is that visible?
Not yet.
Oh, sorry, how about now?
None yet.
Still not.
Yeah.
Okay, let me stop sharing and try to share again.
Oh, okay. We can see.
Yeah.
Oh, you can see.
Yeah.
Oh.
Oh,
sorry. Let me start again. There must be a little bit of a lag for some reason. Sorry about that. I'll try again here. You'd think this was my first time doing a Zoom meeting.
Maybe.
Great. You can see now? Okay, I'm trying to get it to presentation mode if I can here without. Sorry. Okay, are we all set now? So thank you for the opportunity to briefly talk about coronary physiology in the cath lab. These are my disclosures. What I'll try to do in the next 10 minutes is just overview the importance of coronary physiology in the era of the ischemia trial, the importance of the coronary microvasculature, coronary physiology in the acute coronary syndrome patient, and wireless coronary physiology. And just, I know a lot of these are going to be discussed in subsequent talks, so I'll just highlight some thoughts that I have about them because I think they're kind of the key topics currently in coronary physiology. So we're all aware of the ischemia trial and how it did not show any overall benefit with revascularization versus medical therapy, but it did clearly show significant angina relief in patients undergoing revascularization compared to medical therapy that lasted out to 3 years. And this coincides with some work that Dr. Takeshi Nishi, when he was a research fellow with us at Stanford, did looking at a combination of FAME1 and FAME2 patients who were stable and treated either medically or with PCI, and looking at the effect of PCI on their quality of life. And basically what this chart shows is the change in quality of life from baseline to 1 month, with the higher values being greater improvements in quality of life. And what you see is that with PCI, there's a graded increase, and it gets more and more based on how low the fractional flow reserve was, suggesting that PCI really does improve or relieve ischemia, and that improves symptoms. If it was just a placebo effect, we would expect all of these patients to improve in a similar fashion, regardless of what their FFR value was. But you see that there really is a graded effect. And even if you look at delta FFR, so the FFR after PCI compared to the FFR before PCI, the patients who had the greatest change in FFR had the greatest improvement in their quality of life. And then in the FAME2 trial, we found that at 5 years, there was lower rate of myocardial infarction in patients who had low FFR when they were randomized to PCI compared to medical therapy alone, suggesting changes in hard endpoints too. And that was also seen when you looked at spontaneous MI. And ischemia also found this. They found lower rates of spontaneous MI or non-procedural MI, as they called it, in the invasive arm, the patients who got revascularized compared to the conservative arm. So that correlated very well. So I think, although some people have interpreted ischemia as a negative trial for revascularization, I think we can conclude that it improved revascularization, and particularly PCI, improves quality of life and angina, and also can reduce spontaneous or late MI. Now, the other area I wanted to mention was the microvasculature. We often focus on the epicardial vessel because that can be fixed with stents or bypass, but the microcirculation is clearly important. And we can assess that with physiology, both by looking at microvascular resistance and also looking at coronary flow reserve. And there are studies like this one from Jung-Min Lee, looking at patients who had abnormal microvascular function, both with low CFR and high IMR, having worse outcomes during longer term follow-up compared to the other groups. And this study too, which found that patients with high IMR, particularly if they had endothelial dysfunction, had worse outcomes compared to patients with preserved microvascular function. And then the CORE-MICA trial was a very important study because it showed that we can use this information to help guide therapy and improve patients' symptoms. And so in CORE-MICA, they did a very thorough evaluation looking for microvascular angina, vasospastic angina, or non-cardiac chest pain if everything was normal. And then they randomized patients to this assessment versus just standard of care, and found that by stratifying patients and then guiding therapy based on what the diagnosis was, patients had improved outcomes during follow-up. And then another study that we did, which was a multi-center registry, including a number of centers from Asia, particularly Japan, was looking at the role of measuring microvascular resistance, or IMR, after performing PCI in patients who are stable, and finding that those patients who had high IMR, so they not only had epicardial disease, but they had microvascular dysfunction, had a significantly worse outcome with a higher rate of death or spontaneous MI during long-term follow-up. So I think this is an emerging area of investigation that is going to continue to grow, and hopefully we'll now be able to develop therapies for these patients that'll help improve their outcomes. I briefly wanted to say a few words about coronary physiology in patients with ACS. There's been a lot of question about whether we can rely on FFR or non-hyperemic pressure ratios like IFR in patients who have particularly STEMI, because of all the changes that are going on in the microvasculature, which can lead to variable microvascular dysfunction and transient microvascular dysfunction that can affect FFR. And these changes can also lead to hemodynamic changes in heart rate and blood pressure, which might lead to increase in resting flow and therefore affect your ability to measure non-hyperemic pressure ratios in the non-culprit vessels. Now, fortunately, studies that have looked at the non-culprit FFR have not shown real significant differences when you measure it acutely compared to, a week later. IFR also does not have really dramatic changes, although in this case it was statistically significant, but a small change in IFR in the non-culprit vessel. In this other study that looked at IFR, they did not see a significant change from the IFR in the non-culprit vessel acutely compared to about, 1 month later. However, in this study, they did see a significant difference in FFR, but all of these studies have shown that these changes are small. And so I think we can rely on the physiology, but the question has come up is whether these plaques in the non-culprit territories, are they more active? And maybe even if they have a negative FFR, they're more likely to have events. And that was suggested in this study, which compared stable angina patients to ACS patients, and showed that when you deferred non-culprit lesions based on FFR, there was a higher event rate. But I would argue that the comparison should not be between ACS and stable patients, but it should be whether PCI of these non-culprits that were deferred based on FFR actually improves outcomes compared to medical therapy, because we know ACS is a different group of patients. They're higher risk. They're more likely to have events no matter what we do. So it may not be that this is a failure of coronary physiology. It may just be that this is a higher risk cohort. And so when you look at this graph from that study, you see that the deferred ACS, shown in orange, had higher event rates than the stable lesions, which were deferred. But the treated patients in ACS actually had even higher events. So maybe, if these patients had gotten PCI, they would have a higher event rate. So maybe just treating them medically is the way to go. And this was kind of looked at in the Prospect 2 absorbed sub-study, where the patients had non-flow limiting non-culprit lesions that were randomized. So they were FFR negative and randomized to either bioresorbable vascular scaffold plus medical therapy or medical therapy alone. And you see that there really was no difference in outcomes, suggesting that treating these lesions was no better really than medical therapy alone. And And this was despite the fact that these were felt to be vulnerable plaques based on increased plaque burden when they on IVUS. And then finally, the most recent study, which has raised questions about physiology in non-culprit lesions, was the Flower MI study, which included over 1,000 patients with STEMI and multivessel CAD and randomized them to either FFR-guided PCI of the non-culprit disease or angio-guided PCI. And you see that there was no real difference in death, MI, or urgent revascularization. But some of the reason that there might not have been much difference is because all of the patients included had a STEMI and primary PCI, and likely that would drive most of their outcomes. And then 2/3 of the FFR-guided patients had PCI of their non-culprit lesions. So that portion of patients also was treated similar to the angio-guided. So really, there were only 1/3 of patients in the FFR-guided group who had a different treatment that might be either better or worse. And so I think the study was underpowered because of that. And this is reflected by the average of 1 versus 1.5 non-culprit stents. So really, the degree of treatment was not that different. So when you think of it that way, it's not surprising that the two groups did similarly. In addition, they had no assessment really of peri-procedural MI. That's difficult to assess in a patient with STEMI. But we know that FFR, by avoiding unnecessary stents, avoids unnecessary peri-procedural MI. And so in this study, you couldn't really account for that. So that also may have played a role. So the take-home messages that I have from Flower MI are that FFR-guided PCI of non-culprit lesions in patients with STEMI leads to similar outcomes compared to with angio-guided PCI. And FFR-guided PCI results in medical treatment of non-culprit disease in about 1/3 of patients. So you can avoid unnecessary stents without any real increase in harm, although you don't have a major benefit. One question that we didn't have from the data so far that I hope will come in a sub-study is what percentage of events that happened during follow-up in the FFR-guided patients were due to deferred lesions versus, say, the culprit, vessel that was stented. I think that'll be really interesting to help us understand better the role of physiology. And I'd like to highlight this other study that out of Korea that looked at almost 300 patients, all with at least one lesion with a moderate stenosis that had CTA and FFR, and then the vulnerable plaque characteristics based on the CTA were correlated with the FFR. And what you see down here is that patients who had high FFR, above 0.90, more than 50% had no high-risk plaque characteristic on their CTA. So there was a correlation with the FFR and CTA. Only 3.5% had, more than 3 high-risk plaque features. And then as your FFR gets lower, you see that the percentage of high-risk plaque features goes way up, so that when you get down to less than 0.60, more than half of patients had 3 or more high-risk plaque characteristics, and 97% had at least one. So I think this helps explain how physiology, it's able to identify actually vulnerable plaque. And I think that helps explain why treating lesions with low FFR leads to better with PCI or revascularization improves outcomes compared to medical therapy. And one other point I'd like to make, getting back to whether or not physiology is reliable in these non-culprit lesions, comes from this sub-study from the Compare Acute trial. In that trial, they measured FFR in the non-culprit vessels, and they either deferred or treated. And what you see is that the patients who had low FFR, who were untreated, managed medically, had a much worse outcome compared to those with high FFR that were treated medically. So it would argue that physiology still can identify those lesions that are dangerous versus those that are safely treated medically. So in non-culprit vessels of patients with STEMI, FFR may be slightly elevated and the non-hyperemic pressure ratios like IFR may be slightly reduced, but these changes appear to be minor and in most cases not clinically relevant. And I think coronary pressure-based physiology is still the gold standard for evaluating these non-culprit lesions at the time of ACS. And then just in the last minute, I'll mention that there are a lot of exciting angiography-derived techniques for measuring physiology that have now been developed, and coming up at TCT this fall will be the presentation of the FAVOR-3 China trial, which is a really exciting randomized study looking at QFR, one of the angiography-derived physiology techniques, versus angio-guided for guiding PCI. So I look forward to hearing those results. Enrollment was completed, and as I mentioned, it'll be presented this fall. There are techniques for looking at microvascular resistance using these angiography-derived methods that are exciting as well. So sorry if I ran over a little, but thank you for your attention, and happy to take questions.
So thanks, Bill, for the excellent summary and elegant presentation for the overview of the coronary physiology in the current situation. So that any suggestion, any comments and questions to Bill? So in your last part of the slide, you just briefly mentioned the futuristic approach of the image-derived physiologic assessment, so that if there's a flavor to China, Europe, Japan, results are ready. How do you feel about the position of invasive physiology? So that will that reduce the number of invasive physiology, or that they will be complementary?
Yeah, that's a great question. I think there are limitations to the image or angio-derived indices. There's certain patients where there's just a lot of overlap of the arteries, no matter what angle angiogram you perform, or the vessels may be particularly calcified, which may limit the analyses. And so I think there's always going to be a role for wire-based techniques, but I do envision that in many cases, these image-derived or angio-derived are going to replace or decrease the need for the wire. I mean, it's just, I think once we have more data, like the FAVOR-3 China trial and others that are clinical outcome studies showing hopefully non-inferiority or superiority of these techniques, that'll even encourage more use. I think they'll be more, they'll take less time, they'll be less costly, and just easier to do.
Thanks.
Can I ask Bill a question as well? Hi, Bill. That was an excellent summary. Where do you see all this headed actually? Because there's still quite a lot of scatter for IFR, FFR. Do you see in the future whether we'll combine some of the plug characteristic in prospect in imaging into physiology? How do you see these two coming together to make it even more refined? Because there are downsides to both at the moment.
Yeah, no, you're really highlighting a great point, that every test that we have has its limitations, and no test is perfect. And I think you're right, and I think the field is moving in that direction of combining imaging with physiology, both resting and hyperemic physiology, because both of them have advantages and disadvantages. And so for example, there are OCT catheters that may have the capability of measuring physiology simultaneous with getting imaging, and I know there's other wires that may be able to image and provide physiologic information. So yeah, I think that is the future, and I think there certainly are patients, for example, like in the Prospect 2 study, who have a high FFR, not flow limiting, and they still have events. And how can we best identify those patients and improve their outcomes? And I think imaging will play a key role in that.
So thanks, Bill. So for the sake of time, I think we have to move on to the next presentation. And thanks again. And
yeah, thank you.
Okay, the next present will be by Dr. Bon-Kwon Koo from Seoul National University. I don't need to introduce him because he is very famous in this field. Okay, his title lecture is New Paradigm After Ischemia Trial. Dr. Koo, please.
Okay, so can someone help me to? Okay, so I'm ready to go. So now you can see my slide. Okay, so thanks again for the invitation. So I'd like to talk about the part of my new paradigm after ischemia trial, and there will be some overlap with that Fearon's presentation. We know the ischemia trial very well, and there can be several different interpretations of the results, but as a main outcome, actually there was no difference in a routine invasive versus conservative treatment for patients with stable coronary artery disease and at least to moderate or severe ischemia. So I know that there are several interpretations and several different stories from that ischemia trial, but I think one thing is true, that the ischemia dogma, actually mainly based on MPI, and which we have been taught from our senior teachers, is in danger, and paradigm maybe needs to be shifted from that ischemia dogma. So in that perspective, I think it's very interesting that the new European guideline for stable coronary syndrome adopt the use of coronary CTA and invasive physiology in the evaluation and treatment strategy for patients with stable coronary artery disease. And practical question is what we can do with the CT or other imaging studies and invasive physiology in the cath lab. So in that perspective, I would like to talk about the outside cath lab story, mainly focusing on CTA, and inside the cath lab story, focusing on invasive physiologic assessment. So like in ischemia trial, in general, we are using CTA for excluding the presence of significant disease, and generally we use this number for the CTA. And when the degree is intermediate or moderate to severe, we generally send the patient to the cath lab. If FFR negative, IFR negative, we say that, okay, there's no ischemia and no need of PCI, we just forget about it. Actually, that's a guideline-directed approach. However, we know that there are several behind stories in these images. We know that there are several different plaque characteristics that can impose the higher risk than those without, and what we call that as high-risk plaque characteristics, such as luminaria, plaque burden, low attenuation, positive remodeling, Neptune ring sign, and spotty calcification. So as we already have these imaging devices, even if the physiology is negative, there's a chance that we can have a better stratification of these patients when we integrate the CTA and the physiology. So in this, from a post-hoc analysis of 3-vessel FFR French study, among all patients with high FFR and deferral, or the guideline-directed medical treatment, if the lesion does not have more than 3 or more high-risk plaque characteristics, outcome is really good. But even if high FFR but deferral, if there's 3 or more high-risk plaque characteristics, the event risk is increased almost as 4 times. One very interesting interpretation of this results is that this is the reference, low FFR PCI, and these are the high FFR deferral. So this is the reason why we do not recommend PCI for those lesions, because that the outcome is better even with medical treatment in comparison with this reference. But if the vessel has 3 or more high-risk plaque characteristics, even FFR high under optimal medical treatment, the event rate is numerically higher, so that the combination of these two different information can provide us better risk stratification and may provide us a proper treatment selection for these lesions. So having said that, I'd like to talk about the, in general, concept of the high-risk plaque characteristics. So we know the physiology is good, and also high global disease burden is a matter, and also the local lesion plaque characteristics and local disease burden. So I would like to talk about how we can combine these to better discriminate the patient risk. So each of these elements as a binary cutoff is important prognostic indicator. So low FFR, high global disease burden, presence of high-risk plaque characteristics, high local disease burden is associated with a higher risk in under medical treatment. However, the question is that whether these association between plaque and events, physiology and events, is a simple association, or there's a direct and indirect effect, because as Bill just showed, that there is association between the FFR and number of high-risk plaque characteristics and vulnerability. And to discriminate that, what we did was that the mediation analysis. So high global disease burden, high-risk plaque, and high local disease burden, in terms of the vocal or the clinical events, there's an indirect effect or the association with the physiology for high global disease burden, high local disease burden. So it's natural that if global disease burden is high, FFR will get low, and there's association with the event, except for high-risk plaque. But there's also a direct effect of all these three elements, so that this suggests that the combining of these two will provide a better risk prediction. So in other ways, so what it did was that this machine learning technique, when we found a machine learning based high-risk features, there was a ischemia, high global disease burden, high-risk plaque characteristics, high local disease burden all were high-risk features. And the good thing is that if we combine one by one, and if we combine all together as ischemia, high local disease burden, plaque characteristics, and high local disease burden, we can really see that combining all these four elements can really provide us the risk of the future event in these patients or vessels. So having said that, one very nice thing is that I just talked about this invasive physiology, but using this non-invasive imaging, we can assess all these four different components by the CT scan. And I would like to talk about the other hemodynamics. So while talking about physiology, we generally talk about the FFR, IFR, and other non-hyperpressure ratio, but there are several different hemodynamic metrics, so that we are working with this MRO study, and what we are also working with the MRO2 study to define different hemodynamic metrics to better assess the risk of the future cardiovascular events, especially for acute coronary syndrome. So when we divided plaque according to the presence of the anatomical risk or the adverse plaque characteristics and hemodynamic risks, such as adverse hemodynamic characteristics, such as FFR, delta FFR, versus stress, and APS, we found that as a reference of the APC negative, AHC negative, if there's a plaque, either APC positive or AHC positive, the risk of future ACS is around 4 times higher. And if there's a vessel or plaque has both APC and AHC, the risk for ACS, acute coronary syndrome, is increased almost 12 times higher. So that this is hypothesis generating study, but at least is telling us that the combining plaque characteristics, hemodynamics, or anatomy and physiology can provide us a better information on this. And in the cath lab, people are sometimes skeptically saying that the FFR is just a diagnostic test or it's just a research tool, but there has been several new studies showing that this from Fearon's group and this from SCAR registry showing that the FFR guided strategy can actually reduce the mortality, which is really important for the patient. Another important part is the post-PCI assessment. So there will be several presentations related to that, but I would like to just briefly mention that in the ischemia trial, it was regarded as an optimal revascularization when there's ischemia and PCI. But we know that even if ischemia-directed PCI, when you assess the physiology after the successful stent implantation, there can be a residual ischemia, so that this optimal revascularization should be assessed by the post-PCI physiological assessment as well. And the good thing is that there are many new ways to predict and planning of the optimal PCI strategy. So this is a very diabetes-like disease from left main to the whole LAD. Sometimes we don't know what to do, whole metal jacket, surgery, or the medical treatment. But when we apply the recent technology of co-registration with the sync vision device, you see that even it looks anatomically very diseased, there's some physiologically focal disease, and we can estimate that if we put around 30 millimeter stent, we can definitely relieve the ischemia. And finally, I'd like to talk about the microvascular dysfunction, FFR negative, but IMR CFR positive, because that the ischemia trial in ischemia CKD cohort, actually half of the patients no revascularization because they don't have obstructive disease, even if they have a positive stress test. And in this cohort, there's even no benefit of angina-related health status with the invasive strategy. And I think this is due to the microvascular dysfunction. And we found that the presence of overt microvascular dysfunction is associated with the higher event rate. And in recent analysis of the combined international MCD registry, we found that if the vessel or the patient have high IMR and low CFR, actually the risk for death at MI also increased. So I briefly talk about these outside and inside cath lab for new paradigm after ischemia trial. And I think that the paradigm needs to be shifted or modified. And if we combine all these novel insights into our daily practice, we can definitely improve the prognosis by reducing the hard endpoint. Thank you very much for your kind attention.
Thank you very much for a nice lecture, Dr. Gu. So now it's open to discussion. Is there any questions? No comments? So I will start first. So Dr. Gu, you mentioned that the adverse prac characteristics can predict, even though its FFR is negative, more than 8, still there's a higher chance of event. And also the adding the adverse hemodynamic characteristics really increase the prediction of MACE. And also if we add like adverse clinical characteristics, we can more prediction about the clinical event. So now is next step is how can we prevent that kind of event with the detection of that kind of various factors? So in clinical situation, how we can approach that kind of a patient?
Yes, I think that's a very important question. So that when I say adding this will give you a better discrimination and adding that will give you a better discrimination. So the practical question is how much can be added to have a better discrimination? And why we're doing that? It's because that we know that the concept of vulnerability is actually, the issue is that the very low positive predictive value. Its negative predictive value is good and its positive predictive value is very low, no matter how we assess the vulnerability. So practical question to me is that how I can increase that positive predictability, as current paradigm cannot provide the enough clinically relevant or clinical practical guides. So that's the reason why we are doing that. And while adding some additional point, actually increase the positive predictability, no matter what, it's a local lesion characteristic and whole vascular plaque characteristics, either assessed by the IBUS, OCT, CT, etc. So that's why we are working with that. And another very important thing is that we shouldn't neglect the clinical risk factors. So in your recent elegant paper published in JACC Intervention show that the importance of clinical risk factors for MACE. So if we only analyze the target vascular events, these matters. But if we consider the MACE and hard endpoints, clinical risk factor really matters, so that we have to integrate all those together, but we have to work together how we can do that.
Can I ask a question, Dr. Koo? It was excellent actually, and this is exactly where we should be headed. It's really cutting edge, the stuff you're doing. But putting ischemia and everything into the piece for stable coronary artery disease, where do you see the prediction in terms of what kind of therapy strategies you think then this will help change outcome? Is it prolonged depth, more antithrombotic? Is it a different level of statins, for example? Or is it just truly revascularization of stents? Because I think if you put it together, we don't have a grasp of, after we have this, what is the intervention that you're pitching for that truly change heart outcomes? What are your thoughts on that?
Right, so that I agree that that's also another very important question. So that the simple approach for the stable coronary artery disease is giving hydrostatin and the antiplatelet. So finish. But the thing is that even from the ischemia trial, we found that the spontaneous, if we simply see the spontaneous MI, there is a, almost statistically significant difference in reduction of MI in PCI. So that the question is that how we can select the right target for the PCI to improve the patient outcome. So I know that the portion of that part is low. So we cannot say that just vulnerability or the presence of TICFA is a green light for PCI. So that we have to put additional data to really select the
Sorry, I cannot hear the voice.
Okay, is there any other question or comments?
Okay, maybe a very short question for Dr. Koo. Okay.
Okay.
Dr. Hu, well, you have questions, you go ahead. Okay.
Okay. Okay, very nice talk, Dr. Koo. Now we have a lot of several physiology tools like FFR, IFR, QFR, CTFFR. So how do you integrate these physiology tools in your daily practice?
So now, can you hear me?
Yeah.
Okay, great. So that practically I'm measuring both resting and hyperemic indices, and in our recent studies that if both are positive, the outcome is really bad, and both are negative, outcome is excellent. And in discordant cases, actually in the short term, outcome is similar to both negative, but in the long term, during 5-year follow-up, outcome was similar with both positive. So that the presence of having both may be better than leaving one alone to overcome the limitation of each modality.
Okay, because of time delays, we will move to the next speaker. Next speaker is Professor Jung-Min Ahn from Awesome Medical Center. Now he is working in Stanford. So his title of lecture is Post-PCI FFR. Should we measure it after IVUS-guided PCI? So Dr. Ahn, please.
I can share my slide. Could you share something? Okay. Can you see my slide?
Yeah, good.
Okay, and thank you for having me. It's very honorable to me. So my topic is post-PCI FFR. Should we measure it after IVUS-guided PCI? And this is my conventional thought that IVUS and imaging have a different role for the PCI. The IVUS has a role to decide the revascularization. FFR has a role to decide the revascularization, and IVUS has a role for stent optimization. However, nowadays many interventionists pay attention to the role of post-PCI FFR for the stent optimization. So today, I'd like to raise several issues about the post-stent FFR measurement. What is the best cutoff value, the location of pressure drop, location of clinical events, prognosis of residual diffuse disease. If a post-PCI FFR is very normal, is it optimal, or role of coronary imaging in the stent optimization? It could be somewhat provocative. I'm very welcome to many questions. So first of all, different from the pre-PCI FFR cutoff value, the pre-PCI FFR cutoff value in the previous study usually located between the 0.75 and 0.80. So gradient is very narrow, but compared with the pre-PCI FFR cutoff value, post-stenting FFR cutoff value is very wide based on the previous study from the 0.79 to 0.96. Very wide cutoff value reported before would be understood based on the underlying mechanism of post-PCI FFR. I will explain it later. I think the most important consideration would be the location of pressure drop after PCI. So several studies demonstration the major pressure drop after PCI. Defined PCI study demonstrate that only 38.4% of pressure drop occurred within the stent. So more than 60% of pressure drop occurred outside of the stent. FFR research study demonstrate that only 27% of pressure drop, that means FFR drop, significant FFR drop occurred within stent. So majority of pressure drop occurred outside of a stent. This study is a post-PCI FFR CT study. Only 13% of pressure drop occurred within stent. So this is another study by the Utreski showed the similar findings. Pressure drop mostly occurred distal to the stent. However, the location of events after post-stent FFR is different. This is the instance of stented lesion event. These two studies are done by the Dr. Gu, International Post-PCI FFR Registry, Prospective PCR Registry, nicely reported that the stent-related event, that is the TLR, is 76.6%. The Prospective PCR Registry stent-related event is 76.9%. So majority of clinical event occurred within stent. This is our registry study. So there should be the mismatch between what we want to predict the clinical event and what we measure the pressure drop. So the pressure drop occurred predominantly outside of a stent, but clinical event occurred within the stent. So how to compromise between the two things could be the important issue for post-PCI FFR measurement. This is another issue. What is the prognosis of residual stenosis outside of a stent? FAME trial nicely demonstrated that the investigators calculated the functional residual syntax score, show that the functional residual score has no prognostic value. However, even in the original anatomical residual syntax score had no prognostic value. This is the first paper by the Philippe Jenner-Roux demonstrated that excluding first 10 days, there is the residual anatomical, even anatomical residual syntax score had no prognostic value, or things are very parallel. This is Jun Lee and Dr. Gu's another papers. Based on these papers, we can assume that what is the meaning of post-PCI FFR? Anatomical residual syntax score calculated outside of stent stenosis. When we implanted stent, we don't calculate it. So, but the anatomical residual syntax score had no prognostic value, but in this paper, post-stent FFR has information of both the stented lesion and non-stented lesion, has a prognostic value. So if non-stented lesion event is very low, prognostic value of post-stent FFR is equal to the stented lesion outcomes. So then, if the FFR value is very optimal, post-stent FFR value, for example, more than 0.96, then we can consider it the optimal stent result. Already, Dr. William Fearon nicely reported that FFR value more than 0.96 cannot predict the optimal IVUS cutoff value. Predictive accuracy is only 50%. Flip the coin. Recently, the Just Demon nicely demonstrated and confirmed the previous William Fearon's findings that this paper demonstrated the mechanism of post-PCI FFR less than 0.85, but I like to focus on the mechanism of more than FFR more than 0.85. Look at patient number is only 20%, but even though FFR post-PCI FFR is more than 0.85, suboptimal stenting defined by intracoronary imaging is up to 90%. Focal lesion, under expansion, lumen compromised hematoma, malposition, 90%. So the good post-FFR value cannot guarantee the optimal stent result based on the intracoronary imaging. It's very similar to the IVUS findings. Previous ADAPT-DS study demonstrate that after a successful angiography guided PCI, if you do the IVUS, 74% of procedure can be changed because of additional procedure, larger size of stent, high pressure, long stent, etc., etc. Then, in case of low FFR, low post-PCI FFR, what is the next? Interesting group's dice demonstration that additional procedure based on the low FFR can improve the final FFR. But in this study, the intracoronary imaging used only 9%. Recently, we observed the result of a target FFR study. Target FFR study is randomized compared to the physiologic guided optimal stent strategy and standard treatment. But they failed to show the difference between the physiologic guided stent optimization and control group to achieve the final FFR more than 0.90, no statistical significance. But I was surprised to see the in detail procedural characteristics. Intravascular imaging, they used only 16%. Only 1/3 of patient had an optimal stent strategy applied. Why intracoronary imaging is important? Previously, we demonstrated that the intracoronary imaging guided PSP technique can improve the patient outcomes, pre-dilatation, IVUS guidance, post-dilatation. Yes, without IVUS, we can apply the high pressure. But look at in detail in our previous findings. Without IVUS, we categorized the many scenario with the pre-dilatation, no pre-dilatation, with IVUS, no IVUS, post-dilatation, no post-dilatation. Scenario 4, no IVUS guidance, but post-dilatation. Final stent diameter is only 3. Additional balloon size is only 3.1. So we believe that this kind of post-dilatation may not be effective. Compare with this scenario, scenario 7, 8 show that the IVUS guided additional post-dilatation, larger stent diameter, and compare with the stent diameters, final post-balloon size is bigger than by 0.3. One size, we can use the one size bigger stent. So this is very effective. It could be an effective post-dilatation resulting in improved patient outcomes. So final issue is if we apply the IVUS guided PCI, we have do we have to measure post-PCI FFR? To answer these questions, I analyzed our large registry data. From our registry, we enrolled 1,000 patients, 300 lesions received IPSP, optimal stenting strategy, and 700 lesions did not have received the IPSP optimal stent strategy. This is independent correlation for post-stenting FFR value, overall population, male sex, left band LAD location, stent diameters, stent length is associated with the post-stent FFR value. Imaging guided PSP group, proximal location, and stent length is associated with the post-stent FFR value. So after IVUS guided PCI, optimal stent strategy, diffuse stent narrowing would be associated with the low FFR value. But no IVUS guided imaging guided PSP group, the most significant correlate for the post-stent FFR was the stent diameter, not stent length. So it can be interpreted as that the under-expansion could be the most important correlate for the post-stent FFR. So this is the overall population based on the ROC curve analysis. The cutoff value was 0.86. There was a significant difference between the post-stent FFR less than 0.86, more than 0.86. But we categorize into two groups: imaging guided PSP group, non-imaging guided PSP group. So look at no imaging guided PSP group, the AUC is significant. I'm sorry, it is reversed. Imaging guided PSP group, so AUC is progressive value is insignificant. The imaging guided PSP group, the best cutoff value is 0.83, no difference above the 0.83, less than 0.83. Non-imaging guided PSP group, according to post-PCI FFR value, there is a significant difference regarding the clinical outcomes. This is the estimated risk of clinical event and post-stent FFR according to the IPSP. So the imaging guided PSP group, there is no difference regarding the post-PCI FFR. However, the non-imaging guided PSP groups, high post-FFR clinical outcome was good, low post-PCI FFR clinical outcome is bad. So the interaction was very significant. This is independent predictor, overall population. Interaction was significant. This is very interesting. Imaging guided PSP groups, we cannot find the independent predictors, but very interestingly, non-imaging guided PSP group, stent diameter was a very significant predictor for target vessel failure, and post-PCI FFR was a significant predictor for the target vessel failure. This is a summary of our observation. Significant prognostic interaction between the post-stent FFR and performing the imaging guided optimal stenting strategy. Post-stenting FFR was responsible for the target vessel failure at 5 years in regions treated by suboptimal stenting strategy. For example, angio-guided PCI, while there was no association between the post-stent FFR and the risk of TVF when optimal stenting strategy, that is imaging guided pre-dilatation, stent size, and post-dilatation was performed. Therefore, for example, after the IVUS guided, CAG guided PCI, low post-stenting FFR based on the prognostic value leads to the intracoronary imaging to evaluate a suboptimal stent and correct it by additional procedure. However, if we perform the imaging guided optimal stent strategy, post-stent FFR did not show the prognostic value and thus did not to measure it. So this is my first question. Should we measure the post-stenting FFR after IVUS guided stent optimization? I think no. My answer is no. The more important, I think, upfront intracoronary imaging, not directly by post-stent FFR value, but upfronting intracoronary imaging should be used for stent optimization to improve the patient outcome. Then, when post-stent FFR is necessary, I think two cases: side branch. After crossover, there is a tight side branch. If we want to treat more, please measure FFR because 2/3 of FFR value is above the 0.80. In addition, tandem lesion, there is a 2 lesion. FFR, post-stent FFR would be a good tool to decide the stent or others to implant another stent or not. Thank you for your attention.
Thank you, Dr. Ahn. A very nice lecture. So now we're open to discussion or comment. Is there any comments? Okay, I will do first. So Dr. Ahn, you mentioned that the imaging guidance, if we do the imaging guidance, we don't need to measure the FFR. But if we start with FFR pre-interventional evaluation, then how about your opinion? do we need to measure post-PCR FFR before use of IVUS, or you always do the IVUS or IVUS with FFR guidance both simultaneously? They didn't make too much medical cost. That is another issue. So when we start with the pre-intervention evaluation by FFR, then what we can approach the after PCI?
So thank you, very important questions. But I think after procedure, I don't like post-PCR FFR did not provide the additional information. I think the IVUS or intracoronary imaging is more important, because if FFR is low, we have to do IVUS or OCT. If FFR is high, we cannot guarantee the optimal imaging guided stent result. So in any case, the FFR value cannot predict the optimal stent result. So I prefer the intracoronary imaging after stent implantation, even though I already measured the pre-PCI FFR value. But more important, so far we don't have any information, but if we have further data about the pre-PCI FFR pullback information, it can be associated, it can modify our stent strategy. I don't know this data is not available nowadays, but if we will have such data, I will change my mind. But so far, I will measure the IVUS instead of FFR after stenting.
So I think this is a very, very interesting and very somehow provocative, but a very important study. So that I think that what we found in our another analysis was that in patient with the very low pre-PCI FFR, the half of events occurred in the non-target lesion, so that it's a non-TNR TVR. So that if we simply add up with the moderate or the mild stenosis or the mild ischemia, I think that I agree that your opinion is okay. But if the pre-FFR lesion FFR is very low, I think there should be some value, because most events occurred in the non-target lesion. At least half of the lesion occurred in non-target lesion. And when we recently combined all the data post-stent FFR, actually in the very large number of cases, there was a prognostic implication of post-stent FFR regardless of use of IVUS. So that I agree that your concept is in part adequate, but the question is whether the disease is it's focal or the diffuse, so that that may need to further clarification in further studies. But I think this your concept is basically adequate and will give us giving us a very important insight in analyzing and interpreting the post-PCI physiology.
Thank you thank you, Dr. Gu. Very nice. Thank you for very nice comment. But I think if what is the case if the pre-PCI FFR is very low? Because I think there should be definitely there should be some lesion, another lesion outside of a stent, I think. So that's why it caused the future event. There should be some reason why we didn't treat the outside of a stent title lesion. So it could be some bias in some analysis. So I think yes, if the pre-PCI FFR is very low, in case very diffuse lesion or tandem lesion in the distal, I think in such a case we may have a very low FFR value. So instead of post-PCI FFR evaluation, I think a pre-PCI stent design would be more important than post-PCI FFR value.
Okay, so that it's a kind of endless loop of the imaging versus physiology, but I think it's a very right time to introduce the next speaker, the editor-in-chief in JACC Asia, because he's going to talk about the flavor study which compares the IVUS versus physiology in evaluation and PCI. So Dr. Wang, who doesn't need actual introduction, but he is the first editor-in-chief in JACC Asia, and I really hope that he can lead the Asian Cardiology Society to a very nice, happy, futuristic approach. Dr. Wang, please. So we can hear you. Dr. Wang, we cannot hear you. Oh.
Cannot hear.
So I think Dr. Wang has some audio problem.
Maybe we move to next one first.
Yes. So okay, so that why don't we just move on to the next speaker and come back get to the Dr. Wang's presentation later. So next speaker will be a great friend of mine, Dr. Chang-Wook Nam, and his presentation will be about role of post-PCI FFR. He should be a little bit stressed after Dr. Ahn's talk, but let's see how we can overcome this problem. Okay, great. Dr. Nam, please.
Okay, yeah, actually, it's a kind of a very stressful to after. Can you see my slide?
Yes.
So we can see your slide so that.
Okay. Thank you for a nice introduction. So I'm Chang Nam from Jaemin University in Korea.
Dr. Nam,
yes.
So we are presenting you as a rehearsal mode so that you are using two monitor, right?
Okay. Oh, you have some issue. Okay.
So you have to close and move your PowerPoint slide to a main monitor.
Okay. Again.
Please stop sharing and move your PPT to the main monitor.
Can you see my slide? Still loud?
Yes.
Still to monitor?
No. So please do the slideshow mode. Okay, now it's fine.
Okay, thank you. Sorry about the trouble. So my talk is a role of post-PCI FFR, very similar with Dr. Ahn's presentation, but I will little focus on the clinical practice. So in our daily practice, we use the FFR as a great surrogate marker for ischemia. So we prepare the pre-interventional evaluation whether there is ischemia or not, and do the follow-up the FFR value as a PCI if FFR is lower than 8.0. So in this case, intermediate mid RAD and the tight proximal RAD, and the FFR value was 0.62, and most pressure stable was developed in proximal RAD, and then put the one stent in proximal RAD, but still FFR value is low. So after stenting, measurement of FFR is a kind of a physiologic gain of treated vessel. But the vessel, after stenting of a coronary region, the post-PCI FFR value can be very various. So sometimes very close to 1.0, sometimes very low, so lesser than 0.80. So in very different scenario can be happened after PCI FFR measurement. So we don't know the optimal cutoff value of post-PCI FFR. So previously in bare metal stent era, the best cutoff was 0.90, and then when you use the first generation DES, my study showed also same FFR value, 0.90 was the best cutoff to predict clinical outcome. However, after this study, so many studies was published, but every study had a different cutoff value. Because that's why the Dr. Ahn said that the post-PCI FFR measurement can be valuable. But I may say the optimal cutoff value of a post-PCI FFR can be changed by the study population and type of stent and endpoint and included vessel. So just a higher post-PCI FFR was associated better clinical outcome. So just the relationship between clinical outcome after PCI and post-PCI FFR value was confirmed. So in this case, so after proximal RAD stenting, still FFR value is low. In that case, we can say that because it's lesser than 8.0, we can treat with additional stenting in mid RAD, and the final FFR value was quite acceptable. However, if FFR value is more than 8.0, in this case, how can we what should we do next step? Actually, in this case, mid RCA has tight stenosis and the diffuse proximal RCA and distal RCA region. So pre-stent FFR value was 0.70, and then we put stent mid RCA with one stent. After stenting, we can detect the value of 0.83. But we have to remember not only just the number of 83, but also we can check with a pullback analysis trans-stent pressure gradient. And also we have to compare the pre-interventional FFR value and the post-PCI FFR value also. So first, trans-stent pressure gradient is very important because as Dr. Ahn mentioned that even though we measured FFR, but there can be something inside of stent. So high trans-stent pressure gradient can be a useful predictor or indicator of suboptimal result, such as underexpansion or edge dissection. So if you measure the post-PCI FFR, especially you can detect when you detect high trans-stent pressure gradient, it means we need additional procedure or additional evaluation using EBG device. And also not only in trans-stent pressure gradient or in-stent pressure gradient, but also we have to concern about the residual non-target region disease. Therefore, Dr. Gu and Dr. Ri do the very elegant study, not only absolute gain of FFR, just the post-PCI FFR value, but also the percent increase of a pre and post PCI. So if the percent FFR increase more than 15%, their outcome will be very good. So if you merge the absolute gain and the relative gain, so if the patient have a very low post PCI FFR or very low percent increase, their outcome will be very poor. But if the post-PCI FFR is very high, and also the percent FFR increasement is enough, their outcome will be very good. So we can use the post-PCI FFR measurement to predict the clinical outcome. So in this case, how can we interpret our procedure? First, trans-stent pressure gradient was 3. So it means kind of a very low stent pressure gradient. It can be an indicator of successful stenting treatment. And also, how about the percent increasement, pre and post? High FFR percent increase can be an indicator of optimal PCI result. And how about the number of very low FFR value, final 0.83? Low final FFR value can be an indicator of residual disease burden, not indicator for additional procedure, but we have to focus on for the aggressive medical therapy in that kind of patient. So I may say the trans-stent pressure gradient and the relative gain is very important when you measure the post-PCI FFR. And another post-PCI FFR measurement is a side branch, jailed side branch FFR measurement. So when you meet the bifurcation region, this kind of bifurcation, non-left main bifurcation region, we usually provisional approach to the simple crossover stenting, and then we frequently find the jailed side branch ostium. And Dr. Gu or Dr. Ahn already do the great study. So there is a anatomic and functional discrepancy in jailed side branch. And even though we open that kind of a side branch, we cannot make a better outcome in, with a complex additional procedure. But the non-left main bifurcation side branch is not a big deal because the territory is very small. However, how about in circumflex left main bifurcation? In this aerated osteal disease, you may try to with one stent simple crossover stenting and pop. The final result was like this. Even though left main and aerated quite acceptable, but the ostium of circumflex a little bit jailed after simple crossover stenting. Current EBC consensus or recommendation, just kissing, pot, kissing, refot. But if you measure the FFR is high. In that case, even though we treat with medical therapy, until 5 years, their outcome is quite acceptable. If FFR is low in just this kind of jailed circumflex, their outcome will be very poor. In that case, we have to do additional complex procedure. So current practice by EBC guideline, just a simple crossover stenting with additional complex procedure, pot, kissing, repot, and medical therapy. But if we follow the FFR guidance, just the simple crossover stenting and with pot and measure the side branch FFR, if FFR is high, just medical therapy without additional complex procedure. But if FFR is low, we have to do additional procedure. So FFR guidance for compromised side branch after main vessel stenting will reduce the unnecessary complex procedure. The final indication of a physiology post-stent FFR measurement is a kind of a functional concept. Dr. Ahn mentioned that that is not clinical beneficial, but some studies showed a different result. Previously, I introduced the combined anatomic and physiologic scoring system as a functional syntax score is a pre-intervention evaluation. So functional syntax score can lead classification of a patient risk and then better clinical discrimination prediction. Similar concept can be applied after stenting. So residual functional syntax score concept. So if number is high, it means that we do not do the functional incomplete revascularization. In that case, the MACE rate is relatively high. Not only just the MACE, but also death MI rate increase in incomplete functional revascularization patient. So combined anatomy and physiology scoring system after PCR, like a residual functional syntax score, discriminate the risk of adverse event better than just anatomic or just the physiologic assessment alone. So ladies and gentlemen, this is my summary slide. Post-PCI FFR is an indicator for physiologic gain of treated coronary artery and related with clinical outcome. And also, the absolute and relative FFR gain can be a good indicator of optimal PCI result. So we can follow the kind of a procedure. And also, the FFR in compromised side branch can reduce the unnecessary complex bifurcation procedure. And combined anatomic and physiologic scoring system after PCI can better discriminate the risk of adverse event. Thank you very much for your kind attention.
So thank you, Dr. Nam. So now this topic is open for discussion. So Dr. Ahn, do you have any comments for this talk?
Thank you. Thank you.
Yeah, I fully agree with the Dr. Nam's presentation.
Can you hear me, Dr. Nan?
Yes, please.
Hi, Dr. Nan. Wonderful presentation. I have just one short question. How do you measure the delta FFR? You know, for some kind of lesion with diffuse disease, it's very hard to measure the delta FFR. The from the distal part to the proximal part of the vessel is gradually changing. Mm-hmm. So how do you calculate the delta?
Actually, that is a very important point. So when you measure the FFR, there sometimes it kind of a merge of mixed of focal and the diffuse disease. In that case, we have to understand the angiographic finding. So sometimes we have to stop some point and then wait for the FFR value and then move to proximal part and then stop again, and then we can see within 2 points the difference of FFR, delta FFR can be detected. In that's a way to how to understand the physiologic change of a coronary lesion. But it's a kind of a little bit tricky, especially in diffuse disease. In that case, sometimes we cannot find out the stent of the segment. In that case, sometimes we need the imaging guidance. So as Dr. Ahn mentioned, that I think in our daily practice, in my opinion, if we start with FFR guidance pre-interventional, then after stenting, you measure the FFR after PCI. Then if FFR value is high enough, in that case, we don't need to evaluate again with another imaging device. But if the post-PCI FFR value is lesser than your expectation, in that case, especially in the inside of a stent, trans-stent gradient is high. In that case, I think imaging guidance is very helpful to prevent the patient adverse outcome.
I have one question to Dr. Nam. So how to compromise, I think it could be contradictory. How to compromise both the FFR improvement and post-PCI FFR has the prognostic value?
What the meaning
I mean if the post-PCI FFR improvement is very good, even though the post-PCI FFR is very low, patient outcome was good. So, but according to the 4 different groups, only patients with low post-PCI FFR improvement with low post-PCI FFR value, that group only have the worst clinical outcome. Other 3 groups has similar good prognosis. So how to compromise to me, it could be a contradictory between the low post-PCI. So how to compromise the 2 different findings?
Actually, we mentioned that the disease severity is not only just focal, but also the diffuse severity of disease. So if there is a residual disease, in that case, we cannot get the high post-PCI FFR value. In that case, we have to concern about whether we can get enough percent increasement in that case. If we can get the high post-PCI FFR value or high percent increasement, that in those cases, PCI will be very beneficial. So in that case, we have to see the pre-intervention FFR measurement. We have to see the focal pressure step up. If there is enough focal pressure step up, even though it's very FFR or very low FFR value, we can approach with revascularization therapy like a stenting. But if there is no even a very low FFR value and then there is no focal pressure step up, in that case, it is very hard to improve the post-PCI FFR and the percent increase. In that case, it's not indication for the revascularization by stenting.
Thank
Hi,
you.
Dr. Nam.
Yeah,
very nice talk. From the Dr. Ahn's talk, he suggests use images to guide the stent optimization. So do you think we can use FFR pullback to predict the IVUS results? Because in the daily practice, a few patients can pay the cost for both IVUS and FFR.
Yes, I totally agree. The issue is cost. If we can neglect the cost, we have to use the both of the system, FFR and imaging guidance, to improve patient outcome. But if we have only a choice of a physiology guidance, we have to measure the post-PCI FFR measurement, and then if we find out the instant pressure step up more than 4 or 5, it means there are high chance of under expansion or active complication. In those cases, we have to do additional evaluation. But if instant or transstant pressure gradient lesser than that number, in user practice, we don't need to additional evaluation in those patients.
So I think this area needs more research, and we have to understand the limitation of each modality. And one thing I have to say is that for the post-PCI delta FFR cross-stent, its negative predictive value is low. So even if it's good, but it does not always guarantee the success of stent, and that's why Dr. Ahn stressed the importance of imaging, so we need further data in this issue. So for the sake of time, I think that we have to move on to the next speaker, and I hope that Dr. Wang is ready for his important presentation for this series. So Dr. Wang, please.
Sorry for delaying my presentation. Can you see my PPT now?
Yes.
Right now. Okay, thank you. So I changed my computer. Okay, thank you for all of you to join JACC Asia webinar series, Coronary Physiology Update. So I'm going to deliver my presentation. I'm going to introduce the FLAVOR and the FLAVOR-2 studies. My content is going to cover the 4 topics. First, I will introduce you the background. Actually, I don't think I need to take time to introduce the background. Like so many speakers today, you already provide strong evidence to support the FFR-guided PCI strategy has a significantly meaningful than the angiography-guided PCI to have a best outcome. This is actually the study we work with Dr. Koo. This is a subgroup analysis. So among this patient with deferred PCI procedure, for this patient with FFR larger than 0.8, have much better outcome than those patients with FFR lower or equal to 0.8. So what is about the IVUS guided PCI strategy? Still, we have so many evidence to support the IVUS guided PCI strategy, provide the patients better outcome for than the angiography guided PCI, especially for those patients with left main diseases. So here is some evidence, like the ADAPT-DES study. So compare with angiography guided, IVUS guided PCI significantly decreased the MACE by 33%. So both in complex and STEMI patients. So FFR and IVUS, as we know, the FFR is a kind of the functional evaluation. However, IVUS is an imaging evaluation. So both of them are nice tools. Then which should we select or prefer. So that's why we carried on. Actually, we work with the Dr. Koo. Actually, he always contribute a lot of original thinking for the flavor study and the flavor 2 study. So what is the rationale for IVERS versus FFR? Maybe FFR and IVERS are not antagonistic, but rather than cooperative elements or cooperative parameters. So can these two be compared? So I think we actually Dr. Koo and Dr. Koo's team and my team, we worked together for a long time. So we think we still need a comparison of these two methods, because first, so these two strategies are commonly used method in selecting the patients who need a PCI and to optimize PCI. And no previous direct head-to-head randomized comparison of the two strategies in terms of clinic outcome and clinical relevance. So we can determine which is more important. So selecting who to treat versus selecting how to treat. So the two parameters are not conflict. So they may work together for achieving better outcome for our patients. So the whole title of flavor study is fractional flow reserve and intravascular ultrasound for China outcomes in patients with intermediate stenosis. The primary object is to compare the efficacy of FFR-guided PCI strategy with IVERS-guided. So in patients with intermediate coronary stenosis. So the working hypothesis is FFR guided PCI strategy will show non-inferior rate of patients-oriented composite outcome (POC) at 2 years after randomization compared with the IVERS guided PCI strategy. Dr. Koo and Dr. Tak and I, so 3 of us work as a principal PI. Totally, there are 18 centers included for the clinical trial. So 11 in China and other 7 in southern in Korea. This is the study design. It is a prospective randomized international multicenter trial. Patient with intermediate stenosis. So the stenosis rate is distributed from 40 to 70% by visual estimation at the proximal and the middle part of major epicardial coronary artery. Randomization is carried on by 1-to-1 to FFR-guided versus IVERS-guided strategy. Here's the inclusion criteria. Age need to be over or equal 18 years. Suspected ischemic heart disease, de novo proximal to middle second coronary lesion in a major coronary artery. So target vessel size need to over 2.5 millimeter by visual estimation. So intermediate stenosis, 40 to 70% of stenosis rate. So on my right side is exclusion criteria. So because of time limitation, I don't want to go one by one. The PCI criteria in the FFR guided group is FFR, the criteria for revascularization is FFR less or equal to 0.8 after hyperemia induction. In the IVERS guided strategy, the criteria for PCI is minimum rooming area, MLA less or equal 3.3 millimeter square, or MLA 3 to 4 meter square plus plaque burden larger than 70%. What is about the PCI optimization definition? For FFR guided strategy, the post PCI FFR is need to be larger or equal to 0.88, or post PCI delta FFR less than 0.05. So for IVERS guided strategy, PCI optimization need to be plaque burden at the standard edge less than or equal 55%. MSA large or equal 5.3 millimeter square, or MSA larger or equal distal reference lumen area. So here's the primary endpoint. Primary endpoint is a patient-oriented composite outcome at 2 years. All-cause mortality, myocardial infarction, including peri procedure MR. So repeat revascularization, put them together. So I don't want to talk more about the second endpoint. Follow-up, the points is post-procedure at 1 month, at 12 months, and at 2 years. The sample size from calculation, we calculate the sample size. So we enrolled 1,700 patients. So randomly divided the 2 groups. So one is for the FFR guided strategy. The other 850 is for the IVAS guided strategy. Totally, we enrolled more than 900 patients from China and almost 800 patients from Korea. We already finished the enrollment. I think at the end of November of the year, we will finish all of the follow-up. End of the August of this year. So now I'm going to talk a little bit about the FLAVOR 2 studies. I think all of we understand. So first, I would like to introduce you the QFR. What is the QFR? QFR is the integration of 3D reconstruction with a modified fluid count. It's FFR-derived parameters. So already there are several evidence studies to support the QFR-guided PCI procedure better than the angiography-guided PCI procedure. So we, following the FLAVOR 1, we designed a FLAVOR 2 study. We just compare the, so in FLAVOR 2 trial, so we just use the angiography, we just use the QFR instead of the FFR to compare with the IVAS guided PCI procedure. Also, we work with Dr. Koo and so many centers coming from both countries. Totally, we are going to enroll 1,834 patients with a coronary artery disease. Will be randomly assigned to two groups. So one is for the angiography-derived FFR-guided strategy. The other is for the intravascular ultrasound-guided strategy. On my left is an inclusion criteria, which is quite similar to the FLAVOR 1 study. On my right side is exclusion criteria. Here's the primary outcome. It's also similar to the FLAVOR 1. So it's the primary outcome still the patient-oriented composite outcome. So including all-cause mortality, myocardial infarction, or any revascularization at 1 year after randomization according to the ARC definition. Now it's time for me to summarize my presentation. A functional test and all intravascular imaging will be the future of a coronary intervention. The series of FLAVOR study will answer the question, will provide more evidence to support these 2 important parameters. So the result will come soon. Thank you very much for your attention.
Thank you, Dr. Wang, for sharing the preliminary data and the perspective of FLAVOR 2 study. So any questions, comments for Dr. Wang's presentation?
Thank you, Dr. Wang. I'm very expecting the result of FLAVOR 1-2 study. I have one question about the definition of a peri-procedural MI, because regarding the treatment, I was treated population may have a higher rate of procedural MI. So it could be very important to compare to strategies. So what is the definition of peri-procedural MI in both the study?
Actually, in our study, we don't have the MI patient be enrolled. May I understand something wrong with your question?
So the definition of peri-procedural MI in the study.
Peri-procedure MI or peri-procedure.
Yeah.
MI, peri-procedure MI is during the procedure. It's very, actually, we don't have many patients for the peri-procedure MI. Hi, Dr. Hu, would you give some idea about the definition?
Yes, I think that's a very important, comments for this kind of study. And you know that recently there has been huge issues related to the definition of peri-procedure MI, so that we changed our protocol according to the recent debates, so that we are using from very conservative to the very restricted criteria for the peri-procedure MI, so that in primary endpoint we have a reference ARC definition peri-procedure MI, but for the secondary analysis, we will include the ischemia definition and other several different definitions. But as mentioned by Dr. Wang, as this includes a intermediate lesion, there's not many cases with very high troponin or CKMB elevation. But I think that's a very important issue to be raised.
Thank you.
Thank you.
Okay, so if there's no more question, for the sake of time, we have to move on to the next speaker. So Dr. Hu, can you introduce the next speaker?
Okay, because Dr. Hu has a conflict with another meeting, so our next speaker will welcome Dr. Lijun Guo from the Peking University Sheng Hospital. So he will present the status of coronary physiology assessment in PCI. Welcome, Dr. Guo.
Good morning, everyone. 大家能看到我的幻灯吗？
No.
我今天给大家分享的题目是在 PCI 术中冠脉生理学评价的状态。刚才呢，我们前面的几位教授呢，其实就于这个 PCI 术中或者是冠心病的诊疗过程当中。
So in my presentation, I will talk about the coronary physiological assessment in PCI, the current status. So how can I go forward with my slide? So anyone who could help me? Okay, now it looks good. Okay. The concept is very clear. Why we are going to do the functional assessment? Because we want to understand the relation between the function and the lesion. You know, angiography will show that 70% or 90%. These are the lines, these are the evaluations of the angiogram. However, sometimes we can't simply link the radiology or angio with the symptoms. However, you know, PCI is never a harmless procedure. PCI may have iatrogenic instability on the plaque, and also for the benign lesions, we are not pretty sure if we are going to put a stent there. So that's why in the clinical practice, we do need something like a FFR to understand which lesion to intervene and which lesion not. So that's why we believe that FFR is a kind of well-recognized indicator, and the functional loss of FFR will reflect the function of those major vessels in the epicardium. So here you can see these are the roles of FFR. Firstly, FFR will help us to develop our strategy. And in our clinical practice, for example, the first study showed that FFR negative lesions do not benefit from a PCI treatment. And also in other studies, FFR positive lesions can induce SCS in the short term. We need to have emergent revascularization for that. And also post-PCI FFR, the restoration of FFR will have close relationship with the patient outcome. And also we understand that FFR is also associated with some economical value. So that's why when we're determining the necessity of a PCI, FFR will be helpful to us. So in the clinical practice, if we use FFR to guide the PCI, or if we use the angel to guide our PCI, we may answer some questions. So this is the disclaimer study. So it shows that the PCI does not improve the patient outcome on top of the medical treatment. However, if you use the FFR to guide the patient for ACS or for stable anginas, FFR will tell us which patient to intervene, and the MACE rate will be reduced. And have a look at the myocardial infarction. It looks that compared with medical therapy, FFR-guided PCI will show its benefit versus medical treatment. So in this study, although very small in size, if a pre-PCI FFR is lower and the FFR gain is higher, or if the patient's symptoms are more severe, we can have a better benefit. So it shows that such kind of functional evaluation like FFR will pick up the right patients from the stable angina population, and then we can understand which to intervene, which not. So you can see that this is a prognostic value. We can see that FFR is closely associated with the long-term prognosis. And this is another study among ACS. If we use a FFR to guide which kind of vessel we should have from the revascularization, you can see that compared from simply treating the appropriate vessel, if we use the FFR to screen the patient vessel, we can find out more targeted vessels to intervene. However, there are some controversies on that. FFR will also change our treatment strategy. We will make the strategy more precise. This is a registration study in France, including more than 1,000 patients. So if we take the angel guided therapy, you can see that there are a lot of patients who receive the improper treatment. Here you can see that if we can do FFR, 20% of the patients who are supposed to receive medical treatment based on the angel evaluation should receive the intervention or PCI. So FFR can find out those kind of patients who need or who do not need the PCI. So you can see that it is more sensitive and more reliable than the angel only strategy. So FFR can help us to evaluate the immediate effect after PCI. Just now we had a very good discussion, which is the cutoff line for FFR, and also FFR is closely associated with the prognosis. This is definitely true. FFR is closely associated with the patient's prognosis. And how to achieve a good target value and how to find out the target. Here you can see this is a study enrolling patients from 1995 to 2015. So you can see that the line is 0.9. If the post-PCR FFR is higher than 0.9, the MACE and other endpoints are much more improved. And you can see if we can't restore to 0.9, for example, 0.84. If you take 0.84 as the cutoff line, it's also predictive. And also the FFR increase, 15% or higher than 15% or lower than 15%. You can see that all proves that the FFR is associated with the outcome. So this study only focused on the PCI segment. That means the segment with the stent there. However, for the patient with a residue lesion, we don't know what's happening to that based on this study. You can see that all patients had a very good radiology or angio results. They are all good if you evaluate with some angio. However, if you use FFR to further screen the patient, you can see that about 1/3 of the patient is in the range of 0.81 to 0.89, and another almost 1/3 of the patient has a FFR lower than 0.8. Just 32% of the patient have FFR more than 0.9. So if we do a further optimization, we will increase the percentage of FFR higher than 0.9. But this study does not show the statistical significance. And for the patient with a final FFR lower than 0.8, with the optimization, we can reduce the patient. We can reduce the percentage of the patient with some FFR lower than 0.8. And in this group of patients, we see statistical difference. So it looks that if the FFR is always low with the optimization, it is a sign that the patient has a diffuse disease, and you need to think about more strategies to deal with that. So I think that there are a lot of good indicators based on FFR. For example, we have no guide wire FFR and also other evaluations. And some of the evaluations are now applied in the clinical practice. So they are highly valuable in diagnosis. And also you can see that all those kind of measurement take 0.89 as the cutoff line, so that we can combine the different things together. And in the clinical practice, we have proven that IFR and FFR had a very good inferiority. However, it is more straightforward, and we can use that in the clinical practice. And also, we are expanding the application and indication of those evaluations. We will firstly do some prediction. For example, the functional restoration with a PCI. And we use IFR pullback curve. We will find that if IFR restore to 0.9, and the IFR pullback is 0.92. So these two techniques are highly consistent with each other. And now we can do FFR based on coronary imaging. We want to put everything together, for example, radiology together with some functional, for example, QFR by Professor Wang. And also we have the functional evaluation based on IVERS or based on ICT. And also in the outpatient clinic, we can also do a CT-based evaluation. And you can see this is a favor 2 and favor 3. They are unblinded, and we are waiting for the result, favor 3. So you can see this is a study comparing QFR versus angiography. We believe that in the future we will have a very good result published, and this is an OCT derived virtual FFR. It has a very good correlation with the FFR. We can improve the predictive value. We can increase the accuracy of OCT. And UFR, which is IVUS-based, also has a very good result. So the summary is that in the clinical practice, we see a lot of functional evaluations which are used in the clinical practice. And from the point of view of accuracy, I think that the functional evaluation, if combined, is has much higher accuracy than any single technique. However, if you do functional evaluation, it's more invasive, and maybe you can do some adenosine independent techniques, and also we start from the simple patients, and also we will guide the optimization intraoperatively to get the best long-term outcome, so that in the for the patients with critical disease, for example, whatever branch you are in or the orifice lesions, we can find it's useful, and also it has a very good role in the diffuse patients. Of course, there are some application in the ACS patients. However, we still want to find out the best indicator for the different indications. So this area is very promising, and we hope that we can help the patients to solve the problems in the future. Thank you.
Okay, thank you very much, Dr. Guo. Very nice overview and summary. So any comments or questions to Dr. Guo? So I will ask first, Dr. Guo, QFR already available in China. So in your daily practice, how will you choose the physiology tools? You will choose QFR first, or choose FFR or IVUS first, or what patient will you use QFR? What kind of patient you will choose FFR first?
好，非常感谢胡教授这样一个很好的一个有临床实用价值的一个问题。
Thank you. This is a very good question. I think that QFR is more straightforward in the clinical practice. And according to our early phase study, QFR is highly consistent with FFR. Of course, we still don't know the long-term data of QFR, but it looks that it will be very good. So in the clinical practice, if the lesion is pretty straightforward, for example, single vessel or the proximal segment, and the lesion is not complicated in morphology, I believe that in those kind of straightforward cases, QFR must be inferior to FFR. And also, for the multi-vessel and for bifurcation, we believe that QFR will be more accurate in these areas, but so far now we are not using QFR for those kind of tricky positions. Anyway, FFR is still the golden standard, because all the measurements actually are based on the FFR, and all the studies are conducted comparing to FFR. So that's why I think FFR is still the golden standard, in particular for some complicated, complex cases like the lesions of the orifice and the multi-vessel or the complex or diffuse lesion. FFR will be better. For the straightforward lesion, simple lesion, and also I will do some running dependent evaluation, or do something like a QFR. So this is my initial understanding.
Okay, thank you, Dr. Guo. Any other questions? If no other questions, we will move to next speaker, Pu Jun. So next speaker is Pu Jun from the Renji Hospital, Shanghai Jiao Tong University. Pu Jun, are you online? Maybe he is still present in another meeting, has a schedule complicated. So maybe we can have the further discussion according to the Dr. Guo's presentation or for the previous speaker's presentation.
So I think we are far behind the schedule. Why don't we move on to the roundtable discussion, and when he's ready, we'll come back to his talk, because we are very far behind the schedule.
Okay. So Dr. Wang. Okay, so we'll move to the roundtable discussion. Dr. Wang, you are the moderator of the roundtable discussion.
朴教授那个讲完了吗？
We will move to roundtable discussion first.
I cannot hear you, so why? I don't understand. Always something wrong with mine. So why I cannot hear your voice? 每次都是我这里听不到，什么道理？
We can hear you.
Okay, now it's fine. So we are going to start the roundtable.
Yeah.
Okay. Okay, welcome you join the JACC Asia series, Coronary Physiology and Update. So now we are going to start the second session. The second session is the roundtable discussion. Welcome the Dr. Koo, BK Koo, Dr. Nam, and Dr. An, and Dr. Tan, and Dr. Zhang Junjie, Dr. Jiang, and Dr. Xinyang Hu to be a panelist. So the first, we are going to invite Dr. Koo to introduce your wonderful manuscript published in the first issue of JACC Asia. To introduce your paper, the title of the paper is Prognostic Implications of Comprehensive Whole Vessel Plaque Quantification using Coronary Computed Tomography Angiography. So please introduce your paper, Dr. Koo, then we will follow you, and then we will have a discussion following you. Welcome, Dr. Koo.
Okay, thanks again, Dr. Wang, for the invitation, so that I'll share my slides. And I hope that now you can see my presentation. Okay, so that I'm very proud that our paper is actually the first original paper published in the inaugural issue. And also this is a real Asian effort from China and Japan and Korea. So I briefly mentioned about the importance of lesion level plaque characteristics either by OCT, IVUS, CT, and the importance of adding this information to the physiology. So combining the local lesion characteristics and physiology can provide us a better risk stratification and may provide a better treatment selection. However, the beauty of this CT scan can provide us a very comprehensive stenosis and plaque feature from the lesion level to the whole vessel level. And today, our paper is focusing on this vessel level, whole vessel plaque and stenosis analysis. So the objective of our study was to investigate the clinical implication of whole vessel plaque quantification over conventional plaque assessments such as a percent diameter stenosis and local lesion characteristics in defining functional significance and the patient risk in terms of the long-term patient outcome. So this is data from combining 3-vessel FFR French study and Kyoto General Hospital Institutional Registry. And from these two studies, we selected 604 patients, around 1,000 vessels who had a CT scan and FFR measured within 3 months. And for this study, we invited several core lab, including the CT core lab and Severance Cardiovascular Hospital, and an independent clinical event committee adjudicated 5-year clinical outcome. And for the definition of high-risk plaque characteristics, by CT definition, we use these criteria for high-risk lesional plaque characteristics such as MLA, plaque burden, low attenuation, positive modeling, spotted calcification, and Neptune ring sign. And for the high-risk vessel characteristics, we use the total plaque volume, fibrofatty and necrotic core component volume, which is similar to the lipid volume, and percent total atheroma volume. So this is baseline characteristics similar to the general PCI studies, around 36% diabetes, hypoglycemia around 60%, and most were presented as stable coronary syndrome. For the baseline lesion level characteristics, around half was the LAD, and diameter stenosis was intermediate, around 50%, and high-risk plaque local characteristic plaque burden 70% or more was around 40%, and small lumen was 71%, low attenuation 21%, and positive modeling 42%. And as for whole vessel plaque quantification, total plaque volume was 143 cubic millimeter, FFNC volume 17, and percent total atheroma volume was 22. And when we compare the high FFR and low FFR, there was a significant difference in all these high-risk plaque characteristics and whole vessel quantification data. First, what we analyzed was the association between the low FFR and whole vessel plaque by total plaque volume and lipid contents volume and percent total atheroma volume. As you can see here, there's a proportional increase in low FFR vessels as each of these whole vessel index increase. So this means there should be a correlation between FFR and whole vessel plaque analysis, and the results were the same even for the continuous FFR value. So the practical question was that whether adding this whole vessel plaque quantification increased the discrimination ability to define low FFR. So adding local lesion characteristics improves the discrimination ability defined by global chi-square. And nice thing is adding the whole vessel plaque quantification further increased our prediction ability for the ischemia. And the more important thing is that for the clinical outcome in all high FFR deferral vessels, for vocal, higher total plaque volume and higher lipid contents and higher percent total arterial volume has a higher risk in comparison with their counterpart, and hazard ratio was around 4 to 5. And when we simply count the number of high-risk vessel characteristics, as you can see here, 0-1, there was no difference, but if the vessel has 2 or more high-risk vessel characteristics, the hazard ratio for vocal increased almost 17 times. So this really illustrates the importance of high-risk vessel characteristics for patient outcome. One very interesting analysis was that when we divided the vessels according to the number of high-risk plaque characteristics using the cutoff of 3, even for very high-risk plaques, such as 3 or more high-risk plaque characteristics, when there is a 2 or more high-risk vessel characteristics, the risk is almost 7.5 times higher. Another very interesting part is that the low-risk cohorts, for example, high-risk plaque characteristic 3 less than 3, So there was no differentiation of high-risk vessel characteristics in short term, but after 2 or 3 years, there were a discrimination power of this high-risk vessel characteristics, so that this illustrates there's some kind of time difference in acting the high-risk vessel characteristics in terms of the number of high-risk plaque characteristics. So when we adjusted all these clinical risk factors and FFR and percent diameter stenosis, all these 3 and number of high-risk vessel characteristics was still a independent prognostic indicator. But when you see the high-risk plaque characteristics, only some survived after this multivariable adjustment. As I mentioned earlier, it is interesting to see that the landmark analysis or the time variation for the role of the vocal in terms of high-risk plaque characteristics and vessel characteristics. In this hazard ratio curve graph, you see that for short-term outcome, both high-risk plaque characteristics and high-risk vessel characteristics matters, but for the longer-term outcome, and after 2 years, high-risk vessel characteristics only survive after adjustment of all these parameters, which illustrate that for the longer-term outcome, the high-risk vessel characteristics may be more important in comparison with the high-risk plaque characteristic. So in summary, our data suggests that the whole vessel plaque quantification showed the incremental predictability for myocardial ischemia over percent diameter stenosis and HRPC. And number of HRVC had independent prognostic value for long-term outcome in the deferral high FFR vessels. And number of HRVC was a significant predictor of vocal, both within and beyond 2 years in the landmark analysis. So in conclusion, our data show that the whole vessel plaque quantification using CT has an incremental value over lesion level plaque characteristics in defining the presence of myocardial ischemia and also predicting the outcome in patients with high FFR, and comprehensive atherosclerotic evaluation of the whole vessel, in addition to the target lesion, can provide better risk stratification of patients with the coronary artery disease. Thank you very much for your kind attention. So Dr. Wang, you're muted.
Hi, thank you, Dr. Koo, for your wonderful manuscript published in the first issue of JACC Asia. Also, thank you for your excellent introduction. Any questions for Dr. Koo? So may I start with one question? Hi, Dr. Koo.
Yes.
In your paper, you emphasize the full vessel plaque. You input a new conception. Because your evidence coming from the database, coming from the bigger clinical studies. So do you think it's necessary to design even bigger sample, randomized study to further provide the evidence? So do you have this kind of idea?
Yes, so I think that this is a post-hoc analysis of the existing database, so that there should be lots of limitation also, and this includes a relatively low risk cohort because that the 3-vessel FFR French study design includes that the relatively low risk cohort. But still, I think it's natural, so that the adding whole vessel analysis is better than local lesion analysis, so that this is natural. And I'm wondering why we do need a kind of study to validate this. But anyway, this kind of concept should be validated in further studies. But the good thing is that the CT scan, there's several programs which can automatically provide the whole vessel quantification. And even for IVUS, New Boston system has an automatic IVUS whole plaque quantification system as well. So I think there's a more chance that you can use this concept in our daily practice. But I am some positive and negative thinkings about the prospective study, but having a prospective study can better provide the scientific background for this concept.
Okay, thank you, Dr. Koo. Any other comments?
It's a very impressive study, Dr. Koo. One short question. So any CTO patient in this cohort, so do you think the CTO lesion will, the same assessment or add more information to the whole vasculature CT analysis?
So for this study, open CTO was included, but
sorry, my computer out of line, so I changed one more computer.
Cool.
Can you hear me?
Yes, I can hear you. We can hear you. Okay, so I personally think that the CTO is kind of a different lesion subset, but I personally think that even after opening the CTO, the lesion level analysis and also the whole vessel level of plaque burden may have an implication for future physiology. But after opening one caveat of the CTO is that opening the vessel, after opening the lesion, actually the vessel and plaque changes during the follow-up process, and so that I cannot say whether this concept can be applied as they are to the CTO cohort as well.
Okay, thank you.
I have one question, Dr. Koo. Thank you for a very nice presentation. Do you include in your database the patient with a low FFR less than 0.80 included in your database?
So for the outcome, we analyze only the high FFR and deferral, but for the discrimination of low FFR, we included both high and low FFR.
I have one very provocative idea that the concept of a high-risk plaque can apply to the low FFR population. I mean, in ischemia trial, yes, the spontaneous MI can be reduced by the stenting, but overall mortality, there is no difference. So if we apply the high-risk plaque concept into the low FFR population, so we can make a more the sophisticated targeting for the very right lesion and light population. What is your idea?
I think that's a very interesting and important question, but we know very well that as of now, FFR guided strategy is a guideline-based approach, so it is very difficult to have a low FFR deferral. But while analyzing the limited number of cases, so we were also very interested that whether there is a kind of certain cutoff. So for example, FFR 0.7 and 0 low risk plaque characteristics, whether there will be a difference in outcomes, even FFR is low, so that we are investigating that kind of a objective using the limited number of cases, but that there's certain cutoff where the presence of high-risk plaque characteristics does not work in low FFR value, so that the 0.78 presence of low a number of high-risk plaque characteristics works, but if FFR is 0.6, it doesn't work. So I think it makes sense. And also that for the high FFR vessels, there's a different grade can be applied to the high FFR vessels. So if FFR is 0.99, so no matter how many high-risk plaque characteristics, no event. But if it is 0.85, 0.87, the number of high-risk plaque characteristics works. So that I think it's very interesting, and we are still working with that. And I hope that I can show you the data soon.
Okay, thank you.
Congratulations, Dr. Koo, for your excellent studies. I have one comment. According to studies, actually the whole vessel plaque quantification can provide additional prognostic values in deferred vessel with high FFR over the anatomy severity and the plaque burden, plaque lesion plaque characteristic. So according to previous study, prospective study, we all know for triple vessel disease presented with ACS, when we treated with cardiac vessel, actually
according to the IVUS information, the high-risk plaque characteristic, also the protective value for a long-term follow-up. And the recently study we all show, actually there is controversial information about the FFR-based deferred PCI in AMI patients after treated the capillary vessel. I think according to studies, what's your next study design for this particular vessel and the patient lesions, especially for AMI patient with multivessel disease? Will you still use CT analysis parse FFR to predict this lesion, either to defer or to treat it?
I think that's also another very important question. As in our database, we have 80% stable coronary and most are non-MI patients, so that we cannot analyze the impact of ACS for the study. But I truly agree that the ACS patients is different. And most ACS patients, we do not have CT scan. So because they're coming directly from the emergency room to the cath lab. So the value of CT is limited in those ACS patients or acute presentation. And but I still think that there's some value of the invasive imaging because, in Harbin, so several data are coming from ACS non-culprit OCT data and IVUS data, and they show that the presence of the high-risk plaque characteristics is associated with the long-term outcome, even in the non-culprit ACS vessels. So that the question is whether we use this modality or that modality, but the concept still works. So that the question is how we can use this data in the future prospective study. So as I mentioned earlier, one limitation of having current prospective study in terms of study design is that the positive predictive value is very low. So it's very difficult to screen the patients and to have a decent, reasonable sample size calculation. But what I realized is that when we combine the whole vessel and lesion characteristics all together, we can definitely reduce the number of whole population before the screening and after the screening, so that they can work together to design a very decent study combining all these concepts together. Maybe we can have a nice results in the relatively short period.
Thank you very much.
Hi, Dr. Koo. Congratulations for your excellent paper. I want to ask, do you think if we combine the whole vessel plaque quantification with CT FFR, will increase the predictive value for the clinical events?
Yes, I think that's the future. So we know that the CT FFR has around 80% accuracy, so it's not like the FFR, but if we combine the local lesion and whole vessel on top of the CT-derived FFR, I think we can overcome some inaccuracy of the CT FFR, because I personally think that the CT FFR and physiology is one element of the whole disease process of coronary artery disease, so that it shouldn't be all, and FFR is, or the invasive physiology, it cannot be a one shot for all coronary artery disease. So that I would say that if we can combine the even non-invasive hemodynamics, plaque, and vessel characteristic together, we can definitely maximize the benefit of these non-invasive tests.
Thanks.
So Dr. Koo, so when we measure the kind of total vessel analysis, maybe the medical therapy is very important. Maybe your study is very limited patient number, so I'm not sure whether you can analyze the impact of optimal medical therapy. But currently, we are empathized about the optimal medical therapy. Can you tell us about the kind of concept?
Yes, the one caveat or one major limitation of the interventional studies, especially our group physiology study, is that we don't care that much about the drugs, statin, antiplatelet, and ARB, etc. So that's why in the ongoing PRIME CT study, where we started a few months ago, actually very thoroughly investigate the use of statin and level of cholesterol. And I would say that the implication of that drug and level of LDL cholesterol we achieved should be adjusted for the progressed importance of physiologic indices, so that we are in short of data for that perspective, but that should be definitely integrated in ongoing and future studies.
Hi, Dr. Koo and all of panelists. I have one more question for your discussion. Welcome your comments. What do you think about the FFR derived parameters? We have more and more like the QFR and CTFR and other types of FFR. What do you think in the evaluation of the microcirculation? Do you think this kind of the FFR derived parameters can replace FFR? So what is your thinking in future, especially for the microcirculator?
So I think that's a very important question and very practical question, especially in China, because you are now currently use the angio-derived FFR in the daily practice. And there are so many different new metrics from this image-based physiology, because it's image-based physiology and it's a kind of calculation so that we can derive many different metrics. But I personally think that if we derive so that for example, angio-derived FFR, it's derived from the angiographic stenosis severity. And then if something is derived from that assessment, it's a kind of a surrogate marker of surrogate marker and surrogate marker of something. So it will significantly lose the accuracy and level of precision in the predicting of something, so that it's good to have many new values. But I personally think so that the angio-derived IMR or the microvascular resistance is one index, so that it's good. And when you integrate the pressure and the TIMI flow count or coronary flow velocity, we can assess it. But we have to assume the CFR from the resting images. So that's the big limitation of this kind of assessment. So still, it can be a future, but we definitely need more data on that. And we have to admit that we should lose some part of accuracy and precision if we apply these new indices.
Thank you for your wonderful answer. Thank you so much. So it's because of a time limitation, now we move to the second paper. First, on behalf of the JACC editorial board, I would like to thank Dr. Nam to contribute your very good manuscript title with title 5-year outcome of a simple crossover standing in coronary bifurcation regions compared with the side branch opening. This wonderful review was published in first issue of JACC. Welcome you to introduce your paper, Dr. Nam.
Thank you, Dr. Wang. So thanks again for the nice introduction. So I'm again Chang Nam from Gaming University, Dongsan Hospital in Korea. It's really a great honor to have chance to publish my data in first issue of JACC Asia. So my title is 5-year outcome of simple crossover stenting coronary bifurcation region compared with the side branch opening. These are my disclosure. So in daily hour practice, we frequently met the various complexity of a bifurcation region. And some case, like this 3 case, is definitely complex bifurcation region and then definitely need to stent complex procedure. But most of our daily practice, bifurcation region is a very like simple bifurcation region, and then we can approach first provisional approach. When we do the provisional approach, first, the issue is whether we treat the side branch after one stent crossover stenting. As I already show you this slide in previous session, in non-bifurcation region, Dr. Gu and Dr. Ahn showed a very important paper. So there is after simple crossover stent, side branch, non-left main side branch, ostium jailed, but there is anatomic and functional discrepancy. So even though it looks like jailed, but the FFR value is okay. So we don't need to open. Even though we open that kind of jailed side branch, their outcome was not improved by the side branch opening. But issue is whether that kind of concept can be applied in left main bifurcation in jailed circumflex. I also showed that even though it's a very small study, but there is still there is a discrepancy between anatomy and function, even in left main bifurcation. And also, if you follow the FFR guidance, it's quite acceptable. However, those studies are very provocative and a small sample size. But in a real-world registry, there are also some controversy outcome. So after one stent technique, and then whether open side branch good or not. So some studies showed bad with opening. Some studies showed good with side branch opening. So we don't have a clear answer about that kind of issue. That's why we do this study. The aim of the current study was to evaluate the long-term clinical outcome according to side branch opening procedure of a bifurcation lesion after one stent crossover technique with using a second-generation DES from COVID-3 registry. COVID-3 registry is a retrospective multi-center observational real-world study. It was performed between 2010 to 2014 and includes total number 2,648 patients from the 21 centers in Korea. I'd like to show the study flow chart. So I already mentioned the COVID-3 is a second-generation DS using. And then we exclude the 2 stent strategies patient. So the included number of patients was 2,194 patients with PCI in using the 1 stent strategy, including left main bifurcation 682 patients. And we divide the patient as just a simple crossover without side branch opening, and then using side branch opening technique like just side branch balloon and pot, or kissing balloon and etc. Various side branch opening technique. And then check the primary clinical outcome as a 5-year target lesion failure as a composite endpoint of a cardiac death and target vessel MR and target lesion revascularization. In the baseline characteristics, the age was early 60, and then within 2 groups, there is not significant difference in baseline characteristics. Only the significant difference was ejection fraction number, but still is a quite acceptable ejection fraction within 2 groups. And also in terms of medical therapy, very similar, but the instance of a beta-blocker usage was higher in simple crossover stenting. In terms of region location, as you can easily expect, the side branch opening group has higher instance of left main and the LAD region. And also the true bifurcation instance was a side branch group, opening group has a 58%, and then simple crossover stenting is 36%. The stent number is a little bit higher in simple crossover stenting group because the lesion length is a little bit longer. And in terms of QCA, the lateral spacer diameter was a little bit larger inside branch opening group. And then disease burden also a larger inside branch opening group. It's a real world registry data. So usually if there is a more disease inside the branch, it's a higher chance of a side branch opening. But the region length is longer inside the branch group is 5.2 millimeter, but still is very short segment. So if side branch is long, have a long lesion, maybe the patient will defer to the two-stent strategy. That's why this study, even though side branch opening group has a true bifurcation and large plaque, more plaque burden, but still it's very short segment and kind of a very soft true bifurcation is included in side branch opening group. After procedure, definitely side branch opening group has a better angiographic outcome, lesser diameter stenosis and a larger minimal lumen diameter. And in terms of kissing balloon technique, is nearly 77% was performed inside branch, and then the other complex procedure was performed inside branch opening group. And the instance of proximal optimization technique part was around 29% in both groups, no difference. And the UCG of IVUS is a little bit higher inside branch opening group because kind of a complex procedure guided by IVUS. This is primary outcome. In terms of target reason failure, the simple crossover group has a 7.0% until 5 years, and the side branch open group is 6.7%, statistically no difference. Not only primary outcome, but also secondary outcome, death of any cause, no difference. Myocardial infarction, also no difference between two groups. And that any revascularization, target reason, target vessel, there is no difference between side branch opening group or just simple crossover stenting group. Because of a different baseline characteristics, we have to do IPTW adjust analysis, and then that adjust analysis result also, there is no difference between two groups. This is Kaplan-Meier curve. As you can see, the target reason failure instance between simple crossover red line and blue side branch opening group is no difference. Cardiac death and target vessel MI and target reason revascularization is also no difference between two groups. You may think about the, this is a real world registry data, and then also the large number is non-left main bifurcation. And then if we select left main bifurcation, or how about if we just select the true bifurcation reason, here is the result. If we compare the left main or non-left main bifurcation, there is no difference. In non-left main bifurcation reason, simple crossover, side branch opening, no difference. Even in left main bifurcation, statistically no difference, but the side branch opening group has a little bit higher, numerically higher event rate in left main bifurcation. How about the true bifurcation reason? Also similar result. Non-true bifurcation reason, no difference. And true bifurcation reason also statistically no difference, but the numerically side branch opening group has a little bit higher event rate. Not only left main and true bifurcation reason, but also we are very interested in the usage of IVUS can affect clinical outcome. But as you can see, there is no difference. If we just do the simple crossover stenting with one stent technology technique, you don't need to worry about whether you use IVUS or not. And also do POT or not, no difference. And also, when we do this, just the simple crossover technique, there are many argue about the risk of a side branch restenosis rate. So here is the instance of target reason revascularization. Simple crossover and side branch opening group has no difference until 5 years. And if we just select a side branch ostium, side branch related TRR instance also no difference. Portion of a side branch related TRR rate was no difference between two groups. So just to say, I may say that in this COVID-3 real world large registry data bifurcation PCI, when we just do the simple crossover stenting, side branch opening do not affect the clinical outcome. So you may have a question. So why there is no difference? How can explain that kind of mechanism? This study also performed by Dr. Gu is a CFD, using CFD study, just a simple crossover stenting and measure the wall shear stress. The blue line is low wall shear stress, which can induce the augment the neo-intima hyperplasia. And even though it looks like a pinched side branch osteal jail, but the red color means a high wall shear stress, and then it's a very low chance of starting of neo-intima hyperplasia. And also, if we do the side branch opening, just the seeing of osteum looks like enlarged by side branch opening, but what important thing is blue color of main vessel area was increased. That is a very serious problem because the increased number of wall shear stress area in main vessel will make a poor outcome, really clinical poor outcome to the patient. And also, when you do the serial OCT analysis, after just a simple crossover stenting, ostium of a side branch a little bit decreased. But when you follow 1 or 2 years later, the area of side branch ostium was not changed. That's why we can say that it is very safe without any additional procedure. And also, we are concerning about whether that kind of stent strut of side branch opening site, is it okay? So we do the serial follow-up OCT analysis, and then we find out that most of stent strut was covered after 1 year later. Another issue is whether we can say that by OCT, stent strut of side branch opening side was covered, but whether that is a healthy neo-intima or very serious neo-intima. This case was presented during the 2018 CCT and from Japan doctor, and they showed the angioscope of that side branch strut. Not just covered, but it looks very white, looks very healthy. Neo-intima was covered in the side branch ostium strut. That's why the clinical outcome was not different between two groups. So this is, as I mentioned, that non-randomized retrospective observational study, but it's included patient is more than 2,000 of patients. Is really big registry data, and we followed until 5 years. It's quite long follow-up duration. So there are so many limitations in this study, but I may say the long-term clinical outcome of a simple crossover one stent strategy without additional side branch opening procedure in patient with coronary bifurcation lesion was acceptable, even for the left main or true bifurcation lesion, but it's very simple true bifurcation lesion. And therefore, additional complex procedure like lipa, kissing, after with side branch opening may not mandatory for simple crossover stenting bifurcation lesion. Thank you very much for your kind attention.
Hi, thank you, Dr. Lam, for your wonderful introduction to the manuscript published in the first issue of JACC Asia. Any more questions and comments? So from our panelists.
Dr. Nan, congratulations for your excellent studies from the corpus 3 registration. According to studies, actually the beautiful studies show actually there is no need to routine do the side branch opening with kissing blue inflation or port compared with only simple one stent crossover. You also have robust data with a longer term follow-up at either left main or non-left main bifurcation lesions. Actually, this I think real world studies has duplicated and reconfirmed the Nordic 3 studies for simple simple bifurcation lesions. Actually, routine do the kissing bloom inflation. We are not either additional benefit for patients' long-term follow-up. So actually, I would like to know what's your further option or further maybe studies that you will do according to your Corpus 3 studies. In my opinion, so far we still don't have a strong data, especially for left main bifurcation lesions, for simple left main bifurcation lesions. If we treat it with a provisional stenting, do we still do the kissing balloon inflation to open the stent seal? Because in terms of left main bifurcation, the side branch is circumflex. It's a major epicardial vessel. So if we don't do the kissing balloon inflation, we still concern the long-term the stent structure just over the osteoma of a circumflex. And with developed, I think we still worry about the endothelialization where pinched the osteoma of the circumflex. So I would like to have your options. Thank you very much.
Yeah, thank you, Dr. Zhang. Yeah, it's very important question. So in non-left main bifurcation, we don't worry about that kind of concept because already confirmed. Even though FFR is low, it means really functionally jailed the side branch, but clinically no difference whether open or not because its myocardial territory is too small to make a different clinical outcome. But as you mentioned, the circumflex is totally different. It's big myocardial territory. So we are concerning about that kind of area. So first, according to our study result, so if the left main bifurcation is a simple bifurcation, it means the osteum of a circumflex is not much disease. In that kind of that situation, just a simple crossover will be enough. Even though we additional complex procedure to open the strut of side branch circumflex osteum, but there is no clear way to remove the strut of circumflex osteum. Sometimes if you follow the OCT guidance, wiring selection, location of osteum, and also the various complex procedure, but we cannot remove the strut. That's why still no difference in clinical outcome. Especially, I also already showed the OCT follow-up study, serial OCT study showed the covered neointima as looks very healthy. That's why I think it's just a medical therapy user case, medical therapy will be enough. But I may say it will be better to use a thinner strut. And also recently we use a second generation with the biodegradable. That will be maybe theoretically beneficial to cover with a healthy neointima earlier than the thicker stent. That's another concept. But one issue is that our registry include very simple left main bifurcation. So lesion length is very short, and then percent diameter stenosis of a side branch circumflex is also very low, lesser than 50. So we don't include it in our study, very little bit large plaque burden in circumflex osteum. That case, we need more data because we don't have enough clinical data and randomized study about whether additional complex procedure will be beneficial or not. So we have to wait the clinical trial result from the EBC. But unfortunately, EBC, they do hold the patient was perform the kissing balloon. So we need more data in the future.
Thank you.
I have one small question. I think this study is interesting and answer the important question in the case level. Maybe when we open the side branch, actually sometimes the wire in the distal of the osteoma, that means near the carina. Sometimes the wire is near, at the proximal of the osteum, that distal to the carina. So I think the prognosis of the procedure when we open the side branch is different. And maybe the prognosis of these two procedure also different. So I agree that maybe crossover without open the ultium of structure of LCX is not only simple but also safe. But I think the prognosis of different way to open the structure at the ultium of LCX is different.
Yeah, Dr. Pu. Yeah, it's a great point because many Japanese doctors do such kind of way because previous EBC consensus say that when we do after simple crossover stenting, when we open the side branch, they recommend the distal rewiring, right? So, but according to Japanese OCT study, they show that just the angiographic distal rewiring is not enough because even though we do the distal rewiring, sometimes that is wrong way. They cannot remove the whole strut from the ostium. So they said the OCT guidance rewiring can only select the right way. So it is a very limited situation because the OCT guidance bifurcation PCI can be performed very limited number outside of Japan. Still in Asia, we use the very frequently use the OCT, but still the number is lesser than 30%. Outside of Asia, Korea, China, and Japan is a relatively high instance, but outside of Asia, lesser than 10%, sometimes lesser than 5% OCT guidance, especially it's only can be performed by OCT guidance. So if we can do OCT guided rewiring and then do the careful kissing and lip-out technique, I may say the clinical outcome will be good. But if we cannot do that kind of way, just the routine, the angiography, the side branch opening cannot make a better outcome because it's a little bit complex procedure and high instance of complication.
Thank you.
Hi, Dr. Nam. Congratulations.
Thank you.
So if side branch FFR is less than 0.8 after the crossover stent, so is there still no difference between the with and without side branch opening?
Actually, we don't have that kind of a clinical follow-up study. So just doing the FFR measure and then see the clinical outcome. Even though the number is not much, but it's quite big difference clinical outcome. So if FFR, the circumflex FFR is low, if we follow just medical therapy, the event rate is very high, looks high. If FFR is high, it's quite acceptable. So if FFR is low, then what can we do? That is a very important thing. So still, we don't have enough clinical data about that, but we have to open that side branch with just a balloon, or sometimes we need a provisional second stent strategy, implantation strategy. We have to do sometimes. Yeah.
Okay, thank you.
So I think it's the time to close our webinar.
No, Dr. Wang. So Dr. Bu Jun is still should have his lecture because he has another talk in another meeting. So
okay, welcome, Dr. Bu.
Welcome, Bu Jun. Yeah.
Thank you. Sorry. Okay. Thank you, Chairman and panels. My topic is the coronary physiology assessment in acute MI. No disclosure. Let's see this acute MI case. This is a 76-year-old male. He had chest pain and diagnosis as acute anterior STEMI. Angiographic, there is a significant stenosis located in the left main bifurcation and with multi-vessel disease at LAD, LCX, and RCA. Others confirmed significant stenosis. So for this patient, my PCR strategy is primary PCR to left main bifurcation, the crossover with gel balloon, and stage PCR for LAD and LCX. After primary PCR, the final TME flow is TME3. After 1 month, the patient came back for stated PCR for LAD and LCX. However, after 1 month, angiography showed the vessel looks better. In others imaging, the MLA became larger. We performed the FFR for LAD and LCX. FFR is 0.8 and for LAD and 0.9 for LCX, so we do not need protein stain for this patient anymore. We know acute MI is a complex pathology, and microvascular obstruction, tissue inflammation, and spasm could lead to false appearance in STEMI, especially in acute phase. Question 1. Physiology assessment of infarct-related artery in acute MI. We know ischemia impacts distal RA vessel motion by decreasing the vasodilation ability. During acute STEMI, the degree of damage to the infection-related myocardial bag makes FFR in RA may be inaccuracy. Because of maximal hyperemia might be blunted, which could induce the overestimation of FFR. You can see flow may be recovering in the days following the infection, and hence the previous negative FFR in the acute phase of STEMI may become positive in a late phase of STEMI. How about post-PTCR FFR in acute MI? Previous studies show that in stable CAD patients, lower post-PCR FFR was associated with higher vessel-related cardiac events. How about post-PCR FFR in STEMI patients? Recent studies, STEMI patients undergoing primary PCR of infarct-related artery and underwent post-PCR QFR at state PCR. This study showed low post-PCR QFR was an independent predictor of 2-year vessel-related mass. Question 2, physiology assessment of non-infarct-related artery in acute MR. A STEMI with MVD is common, occurs about 50% of STEMI patients undergoing primary PCR. 10 years ago, the guidelines discouraged the non-infarct-related artery PCR at the time of primary or rescue PCR in stable STEMI patients. However, with the development of intervention cardiology, then several studies showed complete revascularization was associated with better prognosis. In STEMI, stage MVD PCR was associated with low mortality compared with the infarct-related artery-only PCR or single-stage MVD PCR. Okay, see, the physiology assessment of non-infarct-related artery in acute phase of STEMI is feasible. In STEMI patients, FFR guided complete revascularization of non-infarct-related artery in the acute and stage setting, resulting a low risk of cardiovascular mass. So current STEMI guidelines recommend routine revascularization of non-infarct-related artery before hospital discharge, especially under the guidance of FFR. Question 3, physiology assessment of microvascular dysfunctions. We know epicardial flow does not equal to myocardial reperfusion. Microvascular dysfunction is an important pathological change after reperfusion therapy in STEMI patients. About 2/3 of patients may have microvascular dysfunction. However, there is no accuracy and simplified assessment of MVD, especially in the acute phase of STEMI. Let's see 2 cases. The first patient is a male patient with capillary lesions at proximal LAD. After primary PCR, the epicardial coronary flow was TIMI flow 3. The second patient was also a male STEMI patient with capillary lesion at proximal LAD. After primary PCR, the epicardial coronary flow was also TIMI 3. So from the clinical and angiographic feature, we cannot see any difference. However, when we follow up these 2 patients at 1 month, case 1 7 days, but case 2 not any events. So why? Similar clinical features of these 2 patients, but different prognosis. We can find the answer from in-hospital CMI. The first patient from the CMI, we can see a significant perfusion defect and microvascular obstruction. Case 2 only the edema on the CMI imaging. We know CMI is a golden standard for MVO. However, CMI cannot be performed at the same time of primary PCR. Now, FFR and IFR are common performed as guideline recommended tests for evaluating epicardial coronary artery disease. For assessment of microvascular dysfunction, 2 methods have been developed, especially IMI. However, both operations are relatively complex. We recently published a study to use QFR for predicting microvascular dysfunction in STEMI. We know QFR can be obtained to use 2 different flow models. One is fixed flow model, calculated by pullback with a fixed FFV that was from previous FF studies, 0.35. The other is contrast flow QFR, CFR, which uses HFV from coronary angiographic. We hypothesized that QFR computation could be used to predict MVO after STEMI. Why? We know when an MVO is present, microvascular resistance cannot be ignored. Result, FFR is overestimated. So FFR and FQFR is identified as QFR in the absence of MVO, and CQFR is identified as QFR in the presence of MVO. So the difference between FQFR and CQFR maybe indicates MVO. In our study, we can see the difference of CQFR and FQFR is an independent risk factor for MVD in STEMI patients, and the cut point was 0.07. I see the two patients. The first patient was 62-year-old male with acute anterior myocardial infarction. The team flow was 3, the CTFC was 32, and we calculated the CQFR and the FQFR. And we can see FQFR was 0.038, CQFR was 0.4. The difference of CQFR and FQFR was 0.02, less than 0.07. QFR system predictor MVO was not happening. So when we perform CMI for this patient, we cannot find MVO. The second patient was a 66 male patient with acute arterial MI. We can see the TFG, the team flow was 3, the CTFC was 52, and we calculated the QFR. FQFR was 0.58, CQFR was 0.71. The difference was 0.13, larger than 0.07. A QFR system predicting the presence of FAD. When we perform the CMI, we can see significant MVO was detected by the CMI. The conclusion. FFR is not recommended for detecting infarction-related artery in acute phase of STEMI. However, post-PCR assessment was feasible for infarction-related artery at stage PCR for prognosis. For non-infarction-related artery, physiology assessment of non-RI in acute MI is relatively accurate. FFR-guided complete revascularization of non-infarction in STEMI is recommended. For microvascular dysfunction, we can see physiology assessment can predict MVO after STEMI intervention. Thank you for attention.
Okay, thank you very much, Dr. Pu. Very interesting study. So any question to Dr. Pu Jun? So Pu Jun, congratulations for your very interesting study. My question is, you mentioned if the data CQFR to FQFR is less than 0.07, it suggests there's no microvascular disease, right?
Yeah.
So what's the evidence for the cutoff to 0.07? So why you choose the cutoff for 0.07?
Yes.
For the data CQFR to FQFR.
Yes. We performed this study to investigate whether QFR, especially the difference of FQFR and CQFR, can predict the presence of MVO in STEMI. We use, as we know, the FQFR is identified as a QFR in the absence of MVO. CQFR is identified as QFR in the presence of MVO. That's why we do not measure the FFR in acute phase of STEMI. But according to this principle, we can use this difference to predict the MVO. The cut point of 0.07 is come from it comes from the regulator analysis. We use different parameters and found the AUC at the cut point of 0.07 is largest. So we use the cut point of 0.07 for the difference of CQFR and FQFR.
Okay, thank you.
So I have one question. So that thanks for sharing the wonderful and excellent idea and the beautiful demonstration of the MBO. The question is, either use CQFR or the VQFR, you're using the resting anatomy and resting flow. So the question is that for you to delineate the hyperemic resistance, you have to put some assumption for CFR and the hyperemic flow versus resting flow. So the practical question is that unless you have a hyperemic flow velocity, so there's some limitation in applying only the resting flow velocity to estimate the hyperemic flow velocity. So that do you have any validation for resting resistance versus hyperemic resistance and applying the resting flow velocity and hyperemic flow velocity?
Yes, I agree with you. Because maximal hyperemia might be blunted, which could induce overestimation of FFR. But for QFR, because QFR is termed computational FFR, the QFR obtained can be obtained with two different flow models. FQFR it comes from previous FFR study. It's fixed, and the contrast flow QFR is actually is use actual HFV from coronary injury. So in our study, we used QFR without the hyperemia. I think because as you said, the QFR is computational FFR, and it has its limitation. But for our study, we only calculated the difference of FQFR and CQFR to find the difference of the real flow speed and the fixed flow speed. So the difference can reflect the presence of macrovascular dysfunction or not.
So I'm very impressed in your very genius idea. So I have one question that the FFR, CFR, the difference would be better than the Timmy frame count or Timmy flow?
Yes.
To predict the MBO?
Yeah. Yeah. The FQFR, the calculation of FQFR is not dependent on the CTFC, but the CQFR. When we calculate CQFR, we use CTFC. That means the frame of the angiographic frame. As I showed in these two examples, the first patient, we used when we calculate the CQFR, we use the CTFC of this patient. This patient is the frame is 32, but the second patient is 52. But for this patient, the FQFR, the fixed speed is the same. So we can see the difference of CQFR and FQFR could reflect the imprints of MVO or not?
Thank you.
Thank you.
If I may have just one last comment, I think it was marvelous. The culprit vessel is indeed difficult to assess, but my question as always is, this QFR method looks novel, maybe IMR, but I think we need to move one step to say that once you get these indicators, what is the therapy that you think will change outcome to reduce events from any form of MVO? I think currently we still don't have very good assessment of where is the target to hit in a STEMI intervention in terms of what to do after the epicardial artery is open. I think we do need more studies to see where it can change the trajectory and outcome for this group of patients. Thanks a lot for the work.
Thank you.
Hi. Because of our time limitation, so now I'm going to close the wonderful webinar. I would like to use Chinese old saying. So all good things must come to an end. 没有不散的宴席. So dear all of our attendees, moderates, panelists, speakers, and audience, highly appreciate your great contribution to JACC Asia webinar series on coronary physiology update. These wonderful and thoughtful presentations with plentiful discussion covers almost all important topics in the field, which will be, I think, very meaningful to our to both of our daily practice and thinking of future clinical studies. So thank you again. Looking forward to meeting you in near future. Thank you. Thank you all.
Thank you.
Thank you. Bye-bye.
Bye.
Bye.
Bye, Dr.
好的，谢谢大家。那司马我们可以暂停掉了，谢谢。